Fine. Open her link. Okay.
Ma'am, please start.
Okay. A very good evening to the team FOGSI represented by Dr. Suvarna Khadilkar today, team ICOG represented by our chairperson Dr. Sheila Mane and Dr. Pratik Tambe, and all the senior obstetricians and gynecologists of our federation. So today we are going to start our 3-day certificate course on complex cesarean section. We will begin with a short prayer to God. So may Goddess of wisdom be kind on all of us. And I will now take this opportunity to invite our chairperson, the dynamic lady, Dr. Sheila Mane, to please give the blessings and a start for this 3-day certificate course. Over to you, Dr. Sheila.
Yeah. Good afternoon, good evening, everybody. And once again, I think we are back with the certificate course this month with the complex cesarean section. And I think all of us, we know that it is very important because with the rising rates of cesarean section, we face more and more challenges and more complex situations. So over a period of 3 days, Dr. Manjupuri and Dr. Mitra Saxena have structured the program so well that I think each and everything, the problem is almost been taken care. And the faculty, I must say that they have chosen a very good faculty who are experienced, as well as a good panel discussions, again from a very experienced consultants. So without taking much time, I wish all the best for this certification course, and I thank all the faculty members for accepting the invitation to participate in this certificate course, as well as the delegates who have registered in such large number. I think we have more than 1,200, and that itself shows that how important is this topic. I thank FOGSI, Dr. Bhaskar Pal, for again giving us the opportunity, and I must thank ICOG also, I being a chairperson also, that through this virtual platform, we are able to reach so many people around the country, even every nook and corner. And at the end of the day, our motto is that we improve the skill, we improve the care, and we save the mothers. So thank you. Thank you once again.
Thank you, Dr. Sheila. That was so nice of you. Actually, I think you are the power behind all these. You are our fuel. So we just have to follow the directions. Can I request Dr. Suvarna, madam? She had joined. I will request Dr. Suvarna to give her good wishes. Meanwhile, Dr. Pratik, I would like you to share your thoughts. And Indira, just call up Dr. Suvarna that we need.
So good evening,
Dr. Pratik.
everybody, and welcome to the 3-day ICOG certificate course on complex cesarean section. Obstetrics is our bread and butter, and it is the primary reason why so many of us actually entered OBGYN in the very first place. Though many of us have now subspecialized into urogynecology, endoscopic surgery, reproductive medicine, colposcopy, obstetrics still remains our first love. And though we take cesarean section for granted, not every cesarean section is the same. And as you will see over the next 3 days, that there are very difficult situations in cesarean section, which maybe you will come across once or twice in a lifetime. But if you are not mentally prepared, if you are not calm and confident enough to guide your assistants, your nursing staff, the pediatricians, and everybody else, if you yourself panic, then that is the beginning of disaster. A calm obstetrician and somebody who is a good lead surgeon who directs the assistants is the greatest resource that you can have in an obstetric OT. And I think Dr. Mitra Saxena and Dr. Manju Puri will convey these messages to you in a beautiful fashion with the aid of so many senior and experienced faculty who are going to deliver their knowledge and share it with you over the next 3 days. I wish all of you all the very best. Let's get started with the academics.
Thank you, Dr. Pratik. Those were some really fantastic sentences put together and every word very meaningful. If Dr. Suvarna is here, I will request Madam to give her blessings.
Madam, I think Madam has logged out. I will just remind her. Okay.
Never mind. I think Shreya, can you please switch on the screen? Yeah. Yeah. So friends, you are all well aware of, the certificate course that is going to be conducted. Dr. Manju Puri, the person who has really influenced all her students and now on a wider scale, all the, FOGSians. She has been the person who's held my hand, and together we've been able to make out this program. So I would like to just say the overview for today's sessions. So, respected dignitaries, esteemed faculty, and dear contributors, and a very, very warm welcome to the colleagues and audience joining us online from across the country. And I can see 463 participants as of now. Today is the day one of the certificate course. We all do routine cesareans, but it is the complex ones that come unannounced, and those which are even simple and they can get challenging anytime, that test our skills and team and our preparations. That's exactly what it is today about preparation. So today we are going to be covering the first part with very basic, that is the checklist and indication based protocols, and then addressing some important places where we should be better prepared, cesarean section in obese women, and what should be the dialogue between the anesthetist and obstetrician to have a smooth ride. Second stage cesarean sections, which are one of the most challenging cesareans and which every obstetrician is facing, is a topic which will be elaborated upon by none other than Dr. Manju Puri. And then let's not think that the malpresentations, breech and cesarean are something that a novice should learn. These are cesareans where anything can go wrong. So we have Dr. Parag to take us through. Dr. Sunil Pandya, I will just take a line. He is an anesthetist par excellence in Fernandez Hospital, who's agreed to do the talk for us today with respect to what an obstetrician should know beforehand when they are dealing with complex cesarean section. After that, we are going to have a very high-powered panel, which is moderated by Dr. Rashmi Bagga and Dr. Mumtaz, and all the senior teachers, professors dealing with emergencies left, right, and center, giving the answers for the panel. So that's about our program today. Next slide, please. Shreya. A word about how we will go. Attendance for all 3 days of the course is compulsory for all those who want to get the certification for this certificate course. At the end of this day, there will be a link of MCQs in the chat box. Those who have attended all 3 days course need to get only 50% on each day, and certificates will be sent within 1 month. I would like to introduce the coordinators for today. Dr. Indira Prasad. Dr. Indira is an additional professor in AIIMS Patna, a graduate and postgraduate of Lady Hardinge Medical College. And she is a brilliant budding endoscopic surgeon and infertility expert. I will not spend more time on reading her CV because you will be meeting her more often in all our programs. The next coordinator for today is Dr. Manisha Bajaj, again professor. They look young, but they are full of experience and knowledge. And more importantly, they are ready to coordinate a 3-hour-long program. And 20 years of experience in high-risk obstetrics and preventing oncology. Again, alumni of Lady Harding. If I'm not wrong, yes, you are from Lady Harding, and a student of Dr. Manjupuri. So now over to you, Dr. Manisha and Dr. Indira, to please conduct this session today. And best of luck.
Thank you so much, ma'am, for such a kind introduction. And my regards to all my seniors, colleagues, and all the delegates who are attending the program today. And it is expected to be really academically full of lots of important information. So now I take the opportunity to invite Dr. Chitra Pandey, ma'am. She is a Director, Harsh Hospital, Prayagraj, and Honorable Secretary, ISOPA, Prayagraj, and member of FDMSC Committee, FOGSI. She is holding very important positions and achievements. Welcome, ma'am. And next, I would like to invite Dr. Uma, ma'am. She's a lead consultant obstetrician and fetal medicine specialist at Rainbow Hospital, Vijayawada, and currently president of Andhra Pradesh RCOG Trust. Welcome, ma'am, to the program. Next, I would like to invite Dr. Vani, ma'am. She is a senior consultant obstetrician gynecologist at Cloud9 Hospital. She is she's a financial secretary at IMA UP State, national coordinator at Sexual Medicine Committee, FOGSI, past president IMA Ghaziabad. Welcome, ma'am. I would like Dr. Chitra, ma'am, to introduce our speaker for the session, the first speaker of the session.
Thank you, Dr. Indira. And first of all, I extend my sincere thanks to respective Dr. Sheila Mani ma'am and Dr. Prateek Tambe sir, an organizing team, for giving me this opportunity. First speaker of the session is Dr. Mitra Saxena ma'am. She's FOGSI Practical Obstetric Digest. She has many publications to her credit, and she's past chairperson of Practical Obstetrics Committee, FOGSI, 2021 to 24. She's also governing council member ICOG 2026 to 27 and vice president FOGSI elect 2027. She has many publications to her credit, and she has organized many state level conferences and hands-on workshops on ultrasound, colposcopy, medical legal issues. We have witnessed many lectures of her in last few years on uterine artery ligation, and that was really very impressive, ma'am, with videos and everything. And among her publications, there are FOGSI Practical Obstetric Digest to January 2025, FOGSI Practical Obstetric Digest.
Good evening. Thank you, Chitra. Thank you so much. Please.
So her passion for academics is very evident. So we welcome you, ma'am.
Thank you.
Please go ahead and enlighten us about your subject.
Is my screen visible?
Yes, very much. Yes, ma'am.
Okay, so friends, it's my pride and my privilege that I am the opening batsman for this certificate course. And Indira, please feel free to put a stop to me if I overshoot my time. So checklists that save life, and talking about indication-based protocols in cesarean section. The idea of our whole exercise is to turn complexity into clarity and anxiety into confidence. So please listen to every talk with an open mind and learning spirit. So we all know how it began, the concept of checklist. It started from the cockpit to the operating room. The image that you saw first was a Boeing model which crashed. And it did not crash because of bad engineering, but a misstep no single pilot could hold on to memory. So decades later, medicine borrowed the same idea. Complex, high stakes, team-based work needs a shared external memory, not just individual expertise. So everyone in the audience, I'm sure, must have heard or read Dr. Atul Gawande's very important, very interesting book, The Checklist Manifesto, and that we don't fail because of ignorance. We just fail because something gets, missed somewhere. And it is very, very important that we should have systems and processes that we do not make mistakes of omission. Now, these are a sample checklist from the aviation industry and also surgical checklist. What we have to remember, how do I decrease the names are coming? Just want to close the box. Can't see my slides properly. So the volume and complexity of what we know it's not possible for one person to remember everything. So that's how the checklist came into being. Now, this idea of surgical checklist was extended to the obstetric emergency, recognizing that it is not one life, but two lives at a time. So that is why, and you cannot have a single one size fits all. So every cesarean, we've been doing it day in and day out. The steps are the same. However, because of different indications, there can be different challenges. So we have to adopt the concept of checklist. Now, what are the costs of admission in cesarean section? We all know that the cesarean section rate is very high. We cannot afford to have PPH or surgical site infection or anesthesia complications because 94% of these complications are due to process failures and not lack of skill. So we all know that at the time when you are in the operative room, depending upon different indications, there could be cognitive overload, which can just make you forget a few important steps, or some antibiotic is not given at the right time. Some problem is being focused on and another complication is being missed. For example, when you're tackling hemorrhage, injury to the bladder could be easily missed. And then there could be times when the staff has noticed that some mistake has happened, but it is not, brought to the notice. So that is why we need checklists in cesarean section, because there are different pressures. It could be time pressure where we have to do crash cesarean, or there could be high stake complications, very complicated cesarean section, which is the talk of the day, or there could be, lot of volume of cases. So a lot of big teams, and you have to give the handover and take over. So that is why it's very important that we cannot go on with the traditional approach of all cesarean sections are done with the same way. We have to have a basic checklist, safety checklist, with specific inclusions based on indications, and standardize the process and individualize the risk. So having made my case, let's go on to indication based protocol. There has to be a general format, and depending upon the indication of the cesarean section, whether it is emergency or elective, whether it is for hemorrhage or it is for PIH or it's for fetal condition, extreme prematurity, we may have to have different sets of readiness for dealing with that cesarean. Now, this is a very, very important slide because this is the actual sum and substance of the whole scenario. There are 3 checkpoints. When we say checklist, there are 3 checkpoints. One is pre-incision sign in. Then the second is intra-op critical steps, the time out, and the last is post-op sign out. What we have to understand is before we make the first, this is a sample of the checklist of Royal College of Obstetricians and Gynecologists. I'm sure all the bigger corporate hospitals are already having these checklists in place, whether they are in the OT or in your patient's file. But I think it is in the operation theater where these checklists have to be in a very visible position. Now, this first checkpoint, that is before you give the first cut, the surgeon and the scrub nurse should be sure that what are the things which are ready, the name, identity, consent, indication, all these things. Everything that is written here is very, very basic, but it has to be made sure that this is done every single time that you do a cesarean section. You cannot ignore even a single, item from these checklists. That Is the blood group done? What is the anesthesia that is going to be given? Any allergies, all the skin tests for local, all these antibiotic skin testing should have been done earlier, and this has to be took. So once this is done properly, the chances of making an error reduces remarkably. Similarly, the scrub nurse has to have, we have everything in place, but someday when some complication has to happen, it's going to happen. The second checklist checkpoint is at the time of giving the incision. So during intra-op, that is, so if there is whatever, depending upon the indication of the surgery, we may have to give important instructions to the anesthetist or to the nurse. So this is the second checkpoint, that is the timeout. And the last, before the patient leaves the OT, this sign out is very important, because the final swab count, instrument, needle count, what is the procedure, estimated blood loss. So all these things need to be filled by the doctor or the assistant or the nurses as per protocol. So golden rule is no incision without timeout, no transfer without sign out. So depending upon the different indications for cesarean, we may have to tweak our checklist depending upon urgency, hemorrhage, or fetal compromise. Now, just giving an example, I'm sure during the course of time, in 3 days, we'll have all our speakers importantly, point out what are the learning points for that particular condition. So if it is a cesarean section for preeclampsia, we know the importance of Maxel before the surgery started, intra-op what anesthesia is given, and post-op magnesium sulfate as well as fluid is not overloaded. So the team has to work in sync. Again, for placenta previa, I'm not going to spend time because this is going to be taken in great detail by our speakers today, tomorrow, and our panel. But suffice it to say that if you're going to do a complex cesarean section for placenta previa or suspected accreta, you have a different, very, very important readiness for all the problems of hemorrhage. Again, for fetal indications, the neonatologist team should be very much there, ready for everything, for intubation, for transfer of babies, and these things have to be talked out before, so that no time is wasted in arranging things once the baby is out. We understand that speed saves neurons and safety prevents maternal harm. So these are just compilation of when we are dealing with difficult, complex cesarean section, if it is adhesions or obesity, all these things, we have to anticipate the problem, prepare, reduce intra-op complications, and so that we have smooth post-op. Again, I'm not going to elaborate on all these because these are going to be covered, but I put that, lighted lamp so that you know that these are those situations where we know we are dealing with a complex cesarean section. Now, the key takeaways of my talk are: complexity needs simplicity, and checklists convert knowledge to action. We have to have a basic checklist which should be there in every OT, and the operating surgeon or the obstetrician is the captain of the ship, should make the specific additions depending upon what is the indication. 3 pause points, as I said: sign in, time out, and sign out. And let us adopt the culture of writing down documentation, because we may be very careful, but if we have not documented, we are in for trouble if any complication happens. Better is possible. It does not take genius. It just takes discipline, and repeatedly same thing. Everybody in the team knows what they are supposed to do when it's simple, and they should know what to do when it is going to be difficult. You may be working in a teaching hospital, corporate setup, or a standalone practice, but are you actually completing a checklist? Yes or no? Is it a documented, thing, or it's just a verbal handout? Please make your own checklist, and don't forget, there is a gossybioma sitting somewhere, or a lost instrument, and morbidity due to poor preparedness to control hemorrhage. And today, patients, society, and administration, nothing is going to spare us. A checklist doesn't replace judgment. It just prevents us from making any mistake. Anticipate all the complexities and prepare the team and the tools. Sometimes you need a specific instrument which is lacking. and that may be one of the reasons why you're not able to accomplish some problem. And stepwise approach to challenges. So from cockpit to an operating theater to now our domain, let us be a pro. Let's reflect, and in our own setup, make sure that whenever we do every single cesarean section, we should be prepared for everything. Thank you so much for a patient hearing. I hope I have not overshot my time. Indira?
Thank you so much, ma'am, for the wonderful talk. It is evident that besides the surgical skill, meticulous preparation, keeping checklist in mind is specific to the case, anticipation of complication is very, very important. Another thing is that there should be a very clear that all the staff and all the members in the OT, they should be assigned their particular work. And very, very important that in cases of emergency, who will communicate with the attendants. So thank you so much, ma'am. Excellent talk.
Thank you, ma'am, for such an excellent presentation, ma'am, and enlightening us on the topic. And now request Dr. Uma, ma'am, to kindly invite Dr. Sunil Pandya, sir, for the next presentation. Thank you.
Yeah, thank you. Dr. Sunil Pandya is very well-known, renowned anesthetist, which I recently shared a workshop along with him in Vijayawada. I don't know if Dr. Sunil Pandya remembers.
I remember.
He's, yeah. So we had a discussion on preeclampsia and anesthesia. Yeah, so he'll be discussing about complex cesarean sections, anesthesia, and the dialogue between obstetrician and anesthetist. So welcome, Dr. Sunil Pandya.
Yeah, thank you, Dr. Uma, for the kind words of appreciation. I thank Dr. Mitra Saxena and the ICOG team for giving me this opportunity to give a talk on this platform. Unlike a dialogue, this will be a monologue, and it can become a dialogue during the question hour. So next 15 minutes, I shall be taking you through this complex cesarean section. What the anesthesiologist should interact, or the dialogue between the obstetricians and anesthesiologist. Nil conflict of interest, and greetings from Fernandez Hospital. Well, if you look at the maternal mortality rate in general, this is the Why Mothers Die audit from the UK, Saving Mothers' Life. Initially, in 1960s, anesthesia was in the second or third leading cause of maternal mortality. And fortunately, now it is unknown entity. Almost virtually there are no direct cause of anesthesia as a cause of maternal mortality, which is very, very gratifying. And one of the reasons why the cesarean section rate is going up across the globe is because of safe anesthetic practices, and also, of course, the improved skills and protocols of obstetricians. Even if you look at the audit of Why Mothers Die, or CEMD from Kerala, Dr. Paide's audit, anesthesia is one of the least common cause of maternal mortality, which again is very, very gratifying. Well, obstetric practice, as has been defined by Dr. Mitra, is little different. It is high acuity, low tolerance of any error, dual responsibility, as is often said, and importantly, time pressure, especially when you have a crisis situation, or when you have a collapse, or when things become category 1 cesarean section. Every birth is routine until it isn't. The safest labor room or obstetric OTs are not those with best equipment, but they are those with the best mindset and best teams. And when I say best teams, it is the camaraderie between the obstetrician and the anesthesiologist which is very, very important. We all know that when mothers die, there is no important cause of maternal death. There is no, I would say, single important cause, but more importantly, it is a missed cues, delayed recognition, and often a system failure. It's not always a personal issue, but it's always a system failure. And that is where, as a team, if we have a good dialogue, we can work out better. So why talk about this topic? Can I have the timer in the screen so that I will keep a watch on it? Yeah. Technology has improved over the decades, certainly. Protocols have improved. Training has improved. Importantly, what we see, the maternal deaths still occur. In Telangana, we are at 42. In Kerala, we are at 29. In Tamil Nadu, we are at again 40 or 38, so on and so forth. But again, in North and Northeast, we are still high. When I say north and northeast, UP, Bihar, and certain northeast, we are still around 90s, which is very, very high compared to internationally. And quite often they are due to delayed communication, delayed recognition, importantly complacency, because nothing will happen. And this is often an issue, especially because the participants, they have improved or increased physiological reserve, and they don't have the classic telltale signs, and they present late and then suddenly collapse. So if you ask me, the 5 important pillars of maternal safety and important dialogue that has to happen, we all know that vigilance, anticipation, communication, teamwork, and compassion. But more importantly, the communication and teamwork is very important. Teamwork, when I say obstetrician, anesthesiologist, neonatologist, maternal fetal medicine expert, so on and so forth. Because the commonest cause of collapse, A, B, C, D, E, U, P, S, I'll come on it a little later. But if you look at this, the only specialty, a surgical specialty where emergencies supersede elective surgeries. And importantly, of the 60% of emergencies, 7% are stat category 1 cesarean section, where you require the topmost error-free anesthesia and surgical care, like placenta accreta spectrum, of course, most elective but unanticipated PPH. We know that 1 minute of atonic PPH is equal to almost 700 ml of blood loss, and 5 minutes of PPH is exsanguination of the mother totally. Hypertensive emergencies, again, bold from blue, sepsis, AFE, cord prolapse, super obesity, which is, again, Dr. Uma is going to talk on this. But more importantly, from an anesthesiologist viewpoint.
Sir, sorry to interrupt, sir. The delegates are asking you to speak a little louder, sir.
Okay. Am I audible? Am I clear now? Yeah. So more importantly, from an anesthesiologist viewpoint, a person or a patient or participant with difficult spine, that is severe scoliosis, is again, or morbidly obesity, you need to give us some time, because when you have a patient, because if you say 99% of regionals, obstetric cesarean sections are done under regional anesthesia, and when we have a participant whose BMI is more than 45 or 50, which is common nowadays, we have an entire shaft of epidural needle going into the patient, and we don't often see the epidural space. So we need equipment like ultrasound machines. Fortunately, available in most of the units. Early PACs, early joint counseling, early epidural in labor, so that we don't struggle with providing regional in the midnight when you have a stat cesarean section, and good quality epidural kits or CSC, combined spinal epidural kits. Pencil point spinal needles. What I have heard is most of the obstetricians, the obstetric centers, the anesthesiologists, they use cutting needle. Cutting needle are not advocated in obstetrics because of high incidence of PDPH. We need to switch to pencil point needles. They're a little expensive, but it's worth investing in pencil point needles. And for the comfort of the mother, programmed intermittent epidural bolus pumps, which are mandatory, I would say. And for difficult GAs, one-odd case, we need to have a difficult intubation kit like video laryngoscopes, HFNC. Like this is the obese participant, BM of almost 52. If you see, yes, you need to have a HFNC, which is there, and a ramp. And it's going to be a problem for you also, because these patients often have panners, which is very difficult. So just to give a choice between when do we choose regional, when do we choose GA, most of the time, as I said, 99% of the time, if there is no contraindication, regional anesthesia is the technique of choice. Only when the patient has coagulopathy, or when there are instrumentation, or patient has plates in the spine, and then we go for general anesthesia. And of course, coagulopathy, which is fulminant. Again, preeclampsia is one of the commonest causes of ICU admission in our hospital, like when I say hypertensive disorders, complications. But more often, what we expect the dialogue is always before you shift the patient for cesarean section, have a recent platelet count, the sample sent within 4 hours of the surgery. ABG electrolytes of paramount importance, because we know that preeclampsia is a vasoconstricted state, and they have hypovolemia, and they have metabolic acidosis. And with magnesium sulfate metabolic acidosis, these patients may pose problems if we give GA, because they may induce delayed recovery. Secondly, hyperkalemia, which is associated with preeclampsia with oliguria. Succinylcholine usage can lead to maternal cardiac arrest, because they can cause malignant hyperkalemia, I would say, which can induce diastolic cardiac arrest. So having electrolytes is very, very important. And importantly, because we know that gestational thrombocytopenia is very common during pregnancy, upon that they have preeclampsia, which also induces low platelets or platelet destruction. We need to have a safe window. So when the trend is falling platelets, better to start an epidural early if she's in labor, especially when the platelet count is more than 70,000. So early epidural, again, PIEB, like programmed intermediate epidural boluses pumps and PCA pumps are very, very useful. Mothers are really comfortable. This is just a picture of our patient, PCEA PIEB pump. Basically, it gives intermittent boluses, on-demand boluses, and patients are highly, highly comfortable with this. Well, when you have this scenario, again, the dialogue is very, very important because we can prevent it. You are all aware about the 4 T's, but I would emphasize on the fifth T and the sixth T. The fifth T is involve anesthetist early in the team. So have a multidisciplinary team, T is for team early, and sixth T is shift the patient to theater early so that with the wonderful light, good anesthesia, good analgesia, you can do the proper re-exploration. And if at all this patient needs peripartum hysterectomy or any of those intervention, internal ligation or any of those things, it's easily done. And importantly, the resuscitation can go very, very rapidly. But importantly, before you shift the patient to theater, assess your infrastructure, because you may be a very competent person, but the infrastructure may not be geared up. You may not have access to blood and blood components. So in that case, you may have to have a dialogue so that you can stabilize and transfer. But more importantly, when you transfer the parturient, it is very important that the stabilization aspects, anti-shock garments and everything is there in on the mother before transfer, so that we don't lose the mother during transfer. Yes, if you are handling such a massive hemorrhage, we need to have invasive blood pressure monitoring, BIS monitoring, which is nothing but the depth of anesthesia monitoring. We need to have warmers because we know that hypothermia is very common. And please, please, please have at least 2 vials of fibrinogen concentrate, because when the mother has major obstetric hemorrhage, 2 grams of fibrinogen concentrate, if it is administered within 5 minutes, it achieves microvascular hemostasis very, very rapidly. It doesn't cost because procuring cryos and FFPs is going to take time, thawing time, transport time. This is just one example where the pH was 6.9, hemoglobin was unmeasurable. We just gave to a tech transfusion, tech guided transfusion, and within 8 hours the ABG stabilized. The point and hemoglobin also improved from not detectable to almost 11, 13 grams. The point which I want to convey is when the patient bleeds, they don't give much time and they bleed torrentially. Hemoglobin can fall as low as 2.6 grams. And this is where you need to have a dialogue with the surgical expertise also, so that if at all they want to use a vascular clamp, they can clamp the aorta or common iliac so that we can minimize the blood loss. We can stop the blood loss. In the interim period, manual compression can be given. And this is what I was talking about, the BIS monitoring, which is very important, and pan warmers. Maintaining normothermia is of paramount importance to prevent THAD. When you have a crisis and collapse, it is always better that you have more people in the team. And this is what we have, something known as situational lead. This person from the anesthesia team, they don't worry about anesthesia. They just quantify the blood loss. They bother about blood and blood components, and they keep a chart about it so that we focus on providing safe anesthesia. So having team, multiple focused team, proper compartmental team, so that they have a proper job description. You're supposed to do this, you're supposed to do this, is very, very important. Again, when you have a cardiac parturient, we know the deadly of cardio-obstetric pentad, tight MS, tight AS, EF less than 40%, Marfan syndrome with ejection fraction more than, Marfan syndrome with aortic dilation more than 4.5, and pulmonary hypertension, primary or secondary. Any of these condition, it is better that you refer the patient early if your center is not geared up. You may be the competent obstetrician, you may have the competent cardiac anesthetist, but the center may not be competent. You may not have cardiologist available for any emergency intervention. So transfer the patient to a higher center. This has to be decided early in pregnancy. You need to have a common agreed plan, team plan with the cardio-obstetric, cardiology, obstetrician, anesthetist, and critical care, and early referrals as has been appropriate. These are the patients who require early epidurals, invasive monitoring, and we need time for these patients. So shifting the patient on an emergent basis is not safe, because we want to provide a safe programmed epidural, which takes about 30 minutes to establish the block. Again, I emphasize availability of PIEB programmed intermittent epidural bolus pumps is a boon for this PAR children because it is very safe. And importantly, we can also give ultrasound guided facial plane blocks. Dr. Mitra madam talked about surgical safety checklist. We moved beyond that. We have something known as anesthesia safety checklist, which we implemented at Fernandez Hospital. But more importantly, the point which I want to emphasize is always have plan A and plan B as a backup, because sometimes plan A fails, you need to activate plan B, and activation plan B should be plug and play type of activation. And importantly, the escalation matrix of oxytocin, this has to be decided pre-surgery, because many a times you all do sign in, sign out, and time out, but we don't decide about the escalation matrix of oxytocin, because when you want to give oxytocin, somebody has a fancy of giving carbitocin, somebody wants to give carboprost, somebody wants to give methylglucometrin, somebody wants to give misoprostol. What you want to give, decide with the obstetrician team. A clear dialogue has to be there so that we can put down type level 1 oxytocin infusion, level 2 this, level 3 how do you want to escalate, so there is no ambiguity. And similarly, before the skin incision, again, make sure that if the patient is going to bleed or peripartum hysterectomy, you put all the warmers and sign out again, as madam has said. It has to be a common consensus so that you talk the same language in front of the patient. Again, invisible safety skill is again a team, because sometimes what happens is a good team is. Yeah, I'll take one more minute. Is it okay? Just one more minute.
Okay.
Yes, sir. Yes, sir.
Yeah. As a team, we work better, and a team mindset is very important because each one of the people, including the porter and the housekeeping chaps, are important. So 5 things that help us to help you, the obstetrician, is during complex cesarean section is inform us early, involve us early, especially category 1 sections or problem cases like cardiac cases or obese parturients. And importantly, we need time to provide safe regionals, safe GAs, and we need to have some basic equipment like video laryngoscopes, HFNC, and importantly, complex is a team diagnosis, and time is a shared resource, and communication is a very, very important clinical skill. And all these things are very, very important, because when you have the metal collapse, A, B, C, D, E, U, P, A, these are the algorithm or acronym that we made in our hospital. I just want to quote this. Last summer, this time I was in Harvard. I was invited for a talk in Harvard, and they have a beautiful system. There's a labor room there. There is a knob here. They just press this knob, and anesthetist is there within minute time, and the cardiac team can be there within minute time. So we need to have some system wherein we can have a good communication system, so that press of the button, you have all the specialists available to help you and your mother, our patient. And this is just an algorithm ABC approach, which we all have to do, because when the postulant collapses, you need the highest skills of resuscitation, including putting the patient on ECMO. We have a series of patients on ECMO with a good outcome, but importantly, we need to have wherewithal to stabilize and transfer the patient, because ordinary team can do wonders. They can recognize the danger early by acting together, and always audit your work, because audit is very important, and that is what lays the benchmark. We initiated the course of obstetric critical care for the first time in the country in 2008, and now it has taken a shape of Save Her, because we have acronym the 3 commonest killers of maternal mortality today: sepsis, hemorrhage, and eclampsia. And we feel every she deserves to go home. And the next course is this October. Anybody interested, they can just ping me or mail me. With this, I conclude my talk. Thank you very much again, Dr. Mitra and ICOG team, for giving me this platform to share. I will be there for questions and answers. Thank you so much.
My one line comment for you, Gagar mein Sagar. How you put in everything. That's the expertise.
Thank you.
Chairperson.
Thank you. Thank you, Dr. Sunil.
Thank you, madam.
Yeah, so I think you well expressed that this teamwork is what works. It's not individual, person doing a great job. Yeah, thank you. And just one quick question. So you recommend Incision for all the patients with preeclampsia?
I would
Because
say
in
that
one of this.
I would say that mothers who have preeclampsia with oliguria, or
Okay.
mothers who have acute weight gain, almost they gain more than 100 to 150 grams a day or 1 kg a week. So those are the women who have very low oncotic pressure. they have very severely constricted intravascular compartment, and because of low oncotic pressure and high hydrostatic pressure, they drive the fluid into the third space, that is edema, ascites, pleural effusion. And these are the patients, because of constricted intravascular compartment, the perfusion of the tissue is reduced and they develop metabolic acidosis. I didn't have time, I didn't, because of paucity of time, I've got many blood gases where the pH is as low as 7.0. And this is certain cocktail of delayed recovery. So better to have ABG, especially parturients who present with oliguria and acute sudden weight gain.
Okay. Yeah,
Yeah.
thank you. Thank you, Dr. Sunil.
Thank you.
Thank you so much, sir. It was actually a extremely informative talk, and you've highlighted that anesthetist is not just the works behind the scene, but actually the backbone of safety in any complex cesarean. So thank you so much, sir.
Thank you.
I would invite Dr. Vani ma'am to give her precious comments on the session, and also inform that Dr. Uma, due to some family emergency, is not able to join. So today we will not be able to have her session. So we can proceed with
Yes,
the
sir.
question answers and
Great insights,
for these
Sunil
two
sir.
sessions.
And thank you, Sheila Mani ma'am, Pratik Tambe sir, and Manjupuri ma'am, Dr. Mitra ma'am, for inviting me. Sir, you have told us that only the skill is not important. A teamwork, a well communication between the team, a composure mind, and as well as the leadership qualities of obstetrician is very important. So as Mitra ma'am rightly said, Gagar mein Sagar. So both of the lectures were like that. Thank you very much.
Thank you. More importantly, what I feel is I often get a call, sir, this patient has heart disease, complicating pregnancy, ejection fraction 40%, she has PPH now, what should I do? Or she has pulmonary hypertension, what urotonic should I give? So like at that moment of time, there is a crisis, planning will become haywire. So when you have a crisis situation, you need to have either pre-programmed algorithms or protocols, or have a team approach and have a escalation matter. It may not take, it may just take less than a minute. This is what is required. Do not give carbetocin in cardiac parturition because it's a long-acting agent. We can't reverse it. So short-acting oxytocin infusion, and second line, if there is no pulmonary hypertension, misoprostol. If there's no pulmonary hypertension, carboprostol. If the patient has pulmonary hypertension, go for misoprostol. So we need to have put down those plans. That is very, very important, because delay in giving proper urotonic also it results in atony. And importantly, what we request is when the patient is very high risk cardiac parturient, we ask atonic PPH, we ask the surgeon to have a low threshold for taking compression suture, so that pharmacologic management and surgical management both helps the patient to achieve hemostatic or vascular hemostasis.
We have added 2 more T's, sir, to our 4 T's. So
That's a big
involving
suggestion.
the anesthetist to the team as soon as possible, and wheel up the patient to the theater as soon as possible. Great insight, sir. Thank you so much.
Thank you, madam.
Now I'll ask some questions, sir. Our delegates have put the questions in the chat box. Will you recommend maternal echo for all?
In fact, this is I'm a part of this cardio obstetric forum nationally. I don't know, most of you are members, or most Dr. Manjupuri is a member of that. Started by Dr. Justin Paul, who is a
I'm also a member.
obstetric cardia. In Tamil Nadu, they have made echo as mandatory. In at least one echo in the last trimester is mandatory. So if you ask me, the way there is a paradigm shift in the type of patient that we are getting, morbid obesities, BMI of more than 35, preeclampsia incidence is 1 in 3 patient is preeclampsia, and so on and so forth. So considering multiple issues, it is better to have at least one echo, because I would say 30% of cardiac diseases are diagnosed with collapse. And you do an echo, the patient goes into pulmonary edema or cardiovascular prolapse or hypotension or arrhythmias, and then it turns out to be either mitral stenosis, which is missed, or patient with cardiomyopathy is diagnosed. So considering the availability of cardiologists, availability of echocardiography, I think better to have echo, but we cannot make it a national protocol, because again, the outreach areas, the peripheral areas, they may not have access. And echocardiographers sometimes can do an echo which can be fallacious, it can be misleading. But yes, when you're working in an institute like government hospital or a private hospital nursing home, better to get an echo done in the last trimester.
But even in an institute like AIIMS Patna, it is very difficult to get echo date for all antenatal patients. They should have a valid reason of breathlessness or then they'll give the date.
Because unfortunately, you need to be a obstetric cardiologist, like Celia Oakley.
I think obstetricians need to be trained with echo. I think then it will be
In
possible.
fact, most of the anesthetists currently are trained in at least eyeballing and four-chamber view. They can get the basic echo done. But more importantly, what I feel is if we sit with the cardiologist and make it a protocol and policy, then I think it'll go even in institutes.
One delegate has asked, can ECG be done in place of echo? So I think ECG cannot replace echo.
ECG again can be, it gives some information, but it not give us contractility. So global T wave inversions are seen in PVCM, but again it will not reveal us cardiac contractility. So ECG, I would say it can be done, but again echo is mandatory.
So I personally feel that the very fact that all obstetricians have become mindful that cardiac problems are something which come out on us, at least an attempt to get an ECG done is like priming the family that there could be some cardiac problem.
Yeah.
What we face in periphery is that no sonologist is ready to do, no cardiologist, because of the PNDT problem. So I think at the level of our FOGSI team and ICOG team, we can do something so that this becomes easier. Take
That's
over.
exactly, that's exactly, Thank you.
So next question.
How much echo is not possible. Echo is not possible in every institute, as you rightly said. But under JSSK, there are facilities. If there is a medical college, most of the districts have a medical college where we can refer the patients and cardiologists are there. Okay. And we can get. So that is also possible. But high patients, like we know they are high risk PIH, OB, elderlies, all these patients now in Karnataka, we get it done for all
What we have done at Fernandez Hospital is we have trained our anesthesia team and obstetric team to do the basic echo. So at least if they find something abnormal, a proper echo is done by the cardiologist. Of course, we may miss out, but possibility of missing out is I would say relatively less common. So the obstetricians are doing high risk obstetrics and perinatology fellowships or fellowship in obstetric medicine. I think we can train those subset. It just requires about I would say 3 to 6 months of high risk echoes, because already they are used to do fetal echoes very, very comfortably. So to get the windows in the mother is relatively, I would say easy. I would say they can get the windows and just read little bit of cardio obstetrics, and that's the easiest way. And then any doubt, refer the patient to a cardiologist for the proper echo.
Dr. Manju, your comments.
Jupuri ma'am to give her comment. She's raised her hand.
Yeah. So basically, thank you, Dr. Mitra and Dr. Pandya, for such excellent talks.
Thank you.
We as obstetricians need to be mindful. Echo may not be possible for all patients if we look at the numbers in India, but I think we need to auscultate the heart of every mother. That is also something which gets missed. And also pay attention to her pulse rate and respiratory rate. And any if we detect, that is, we will detect only if we see it every time, and then also label our patients as high risk. And if we are able to be mindful of all these things, I'm sure that we should be able to identify people who actually need a cardiac evaluation.
So
one can definitely
subtle
see that.
signs, I would say subtle signs like unexplained tachycardia, unexplained tachypnea, progressively increasing fatigue.
That in mind, rather than a universal
those things are
things, your threshold.
Actually, Dr. Manju, as a teacher, has said very importantly that history taking. If a woman says she's dyspneic on climbing stairs and she's pregnant, and we are not doing the examination, we are actually making a mistake.
Absolutely.
So we have to be mindful. Yeah.
Baseline clinical skills cannot be undermined. paroxysmal nocturnal dyspnea is not physiological. It is always pathological.
Yeah.
And
So
diastolic,
someone is asking whether echo should be done in trimester 1 or trimester 3, because there are certain conditions where pregnancy is contraindicated, or it's better to terminate in case in those congenital heart diseases.
So yeah, if you look at the peaks of cardiac output, the cardiac output starts peaking from 8 weeks onwards, but the first peak we see around 16 to 17 weeks when the quickening happens. So 14 to 16 weeks when the quickening happens, when the patient becomes like, generally they present as flu, mild URTA. So whenever the patient presents with URTA around the time of quickening, do not ignore that. Always escalate, as Dr. Manju said and Dr. Mitra said, always escalate. And if you see hear any murmur, then better to refer the patient. And you have a good window of intervention from 20 weeks onwards, if at all the patient needs any intervention. But if you miss out this window, then the second peak of cardiac output happens around 28 to 30 weeks, or around 28 to 32 weeks rather. And this is the peak where again you have a window for medical optimization in terms of diuretics or digoxin or any of those medications to stabilize the cardiac output or cardiac remodeling. Time can be obtained, window can be obtained. And of course, third peak, we can't do anything. It happens in the peripartum period, immediately post-delivery. But again, that can be given, you can give furosemide and you can debulk the patient going in for pulmonary edema. And fourth, importantly, the fourth trimester is also very important because major physiological shifts happen. And sometimes the patient present on the first POD or second PND, where the maximum reduction in colloid operatic pressure happens.
Can we take one or two questions quickly?
Indira, I was just thinking, check out if Dr. Parag is already there or not. So that Dr.
Sir is
Manju
joined,
will
ma'am.
take-
Sir is joined.
Okay. Okay, and just have a look at the time because we have exhausted Dr. Uma's time, I think so.
So we
Yeah.
have question answer time till 5:10, ma'am.
Okay, because Dr. Manju will be home by 5:30. So we will have to ask Dr. Parag to take the next talk. Meanwhile, Dr. Sunil, just give an overview of damage
No,
control
ma'am,
resuscitation
more
in
questions.
5 minutes.
There are two
Once-
questions, ma'am.
Yeah.
One,
That how much
one
fetal
question
energy
from
can
my
be
side.
given?
Madam?
One question from my side.
Yeah, please.
Can
please.
we take questions in chat box, Mitra? Otherwise, it will go on. Yeah,
Okay, then Indira, I think Dr. Sunil, you
Yeah.
please आप हमारे साथ बने रहिए और
ठीक
chat
है।
box में answer करते रहिए.
Okay, करते रहता हूँ मैं.
One question from my side, sir. Do you
Yeah.
put central line in all complex cesarean sections? And do you prefer delayed extubation and or elective oxygenation in ICU?
Yeah, absolutely. That's a very good question. Central line is not necessary for all cases. RTA line is very, very important. But yes, complex cesarean section where you expect massive hemorrhage, then better to have central line. But again, during crisis, during collapse, you need two wide bore or 2 or 3 wide bore cannulas and one RTA line. Central line is not necessary during collapse and crisis situation. Once the patient stabilizes, then you can insert it. But suppose if it's an elective case where you have time, then better to have central line also in situ. And coming to your next question, whether the patient needs planned extubation. See, intubation is always emergent or depending on the nature of cesarean section, but extubation is always planned. So before you extubate a complex cesarean section, following a major surgery, following a major hemorrhage, following patients who are on magnesium sulfate, have a low threshold to ventilate the patient, like electively ventilate the patient and do a planned extubation rather than extubating and reintubating the patient. Because from my experience of 30 years, if the patient does not recover from anesthesia, it is not the anesthetic cause that is responsible. It is failure to understand the underlying pathophysiology that has led to delayed recovery. So and unnecessarily you'll be extubating and reintubating, and that should not happen. So have a low threshold to ventilate the patient electively.
Okay, I think Vidya,
Thank you
now
so
you
much,
start
sir.
the talk, dear. Okay.
Yeah, I
We'll
hand over
invite for Dr.
the
Parag. Yes.
podium to Dr. Manisha to carry on with the second session.
Good evening, all. Now, I would like to, it's my pride privilege to invite our distinguished chairpersons for the next session. So, who all are eminent academicians and highly respected obstetricians. And I invite Dr. Madhuri Chandra, ma'am. Dr. Madhuri Chandra ma'am is president of Bhopal Menopause Society, and she was a former professor in Gandhi Medical College, Bhopal. Madam has many publications and she was also a member of ICOG Governing Council 2017 and 19. Next, I would like to introduce Dr. Poonam Mani ma'am. She is professor in MMC Muzaffarnagar, and she has more than 18 years of experience and has a number of awards to her name. Next, I invite Dr. Jayanti T. Madam is professor in HOD East Point College of Medical Sciences, and she is also highly respected academicians. So I request Dr. Madhuri Chandra ma'am to introduce our next speaker. Madam Dr.
Manisha, I am not there.
Dr.
Please
Madhuri
call
will
Dr.
introduce
Parag.
Dr. Parag.
Yeah.
Next slide, please. Shreya, please change
पत्ते बंद हो गए
Dr. Parag.
ये तो पूरी लाइन बंद हो गई
बंद हो गई
ये चिड़ी का गुलाम पहले बंद होगा
I request the participants to mute their. Madhuri, Dr. Madhuri Chandra ma'am, I will request you to introduce Dr. Parag. Sir.
Sure, it'll be my pleasure. It's a real pleasure to introduce Dr. Parag Biniwala, who's a senior consultant from Pune. He's a PG teacher and unit head at Kamla Nehru Hospital. He's been the chairman of the ICOG. He's been the president of the Menopause Society, Pune. He's been the president of Pune OBG Society, president ISOPAR Pune
Thank
chapter.
you, Madhuri. Madhuri, that's enough. Thank you.
No, let me say a few more words. Peer reviewer, edited and written lots of books and published many articles in journals, and is a very skilled speaker. So over to you, Dr. Parag.
And a very
Thank you, Dr. Madhuri.
Skilled obstetrician.
Good evening. It's indeed a pleasure to be speaking in the ICOG certificate course. So let me thank Dr. Sheila Mani, the chairperson of ICOG, Dr. Pratik, secretary, and the conveners, of course, Dr. Manju and Dr. Mitra for having me here. And I must appreciate the efforts put in by Manju and Mitra because they've talked to each and every speaker and they've, in fact, suggested what they expect out of the speaker. And I think that is something which is very, very important. So in next 15 minutes, I'm going to talk about C-section in I'm going to talk about safe extractions in malpresentations and Mullerian anomalies. Why these C-sections are different? We all know that whenever we are performing a C-section for cephalic, things are rather easy because all you have to do is to catch hold of the head and get it out. But here, we are not sure what exactly is presenting. So it could be a foot, it could be a breech, or it could be even a hand in addition to it. First, let's understand why there are abnormal presentation in women, and then we can have certain maternal or uterine factors like multiparity or uterine anomaly or even abnormal pelvis. Women who have placenta previa, polyhydramnios or oligoamnios do exhibit abnormal presentations, and let's not forget the fetal factors that include prematurity, multiple gestation, and even fetal anomaly. Coming to the Mullerian duct anomalies, and all of us are aware about all these classes. So this is the latest classification. Here we have to understand that many a times these women who have these anomalies do present either with breech presentation or transverse lie. There could be an incoordinate uterine action which results into failure of progress requiring C-section. At times, they come up with pre-labor premature rupture of membranes or even placenta previa, and sometimes there could be an obstruction while the fetal head is descending down. So we have to understand the anatomical challenges that may come across during surgery, which would include asymmetrical incisions because the uterus is totally differently shaped. The anatomy is distorted, and at times there could be an accidental discovery because many a times Mullerian anomalies may not have been diagnosed during the antenatal period. The rudimentary horn, in fact, is something which acts as notorious because we know that there could be a transparent migration resulting into an unwanted pregnancy, either in the tube or in the rudimentary horn, resulting into an obstetric catastrophe. And here we have to counsel our women where we know that there is a rudimentary horn and talk about either a tubal ligation or salpingectomy or even excision of the horn. So there are some important tips we have to understand as far as when we are performing a C-section on a woman who knows that she has an anomalous uterus. Early diagnosis is important based on history, examination, and especially a scan in an early pregnancy. Be mindful about renal anomalies because many times there are associated renal anomalies in these women. These women have to be followed up closely. Good counseling is important throughout pregnancy. Make them aware that C-section is not very easy, and we have to ensure that we document the C-section properly, which could be in the form of correct notes and ideally photographs, which could be handed over to the patient so that she knows what is wrong with the uterus. And of course, before she goes home, it is important to debrief her as far as the future pregnancy is concerned. And counseling plays an important role where we have to explain all these points to them. Coming to the malpresentations, and now these are the commonest indications for C-section. These days, breech or transverse lie are routine indications for cesarean section. Coming to breech, we have to understand that we should not take these cases very lightly because abdominal breech delivery needs the same skills and maneuvers as vaginal breech delivery. All of us are aware about the types. It really doesn't matter when you are performing C-section. You just have to be very, very clear in your mind as to what to expect when you take a nick on the lower uterine segment. When we talk about breech, we cannot stop talking about the term breech trial, which made people aware that there could be more instances of perinatal or neonatal mortality and serious neonatal morbidity, almost threefold. And then people switched on to performing C-section whenever they saw a breech. But the Primoda study talks about the planned breaches vis-a-vis vaginal births vis-a-vis C-sections, and the study found no difference in perinatal or serious neonatal morbidity. But we always have these days a low threshold for C-section as far as a breech is concerned. It is very much indicated in these circumstances, like bad obstetric history or a contracted pelvis, placental insufficiency, PROM, placenta previa, or even prolapse of umbilical cord. So it is important that we evaluate these women properly. Please note that clinical examination is something very, very important where we find out the presentation, the position, and the attitude of the fetus. Taking help of an ultrasound is important. Confirm the position, location of placenta, umbilical cord, and note the amniotic fluid volume. Confirmation on table is important. It takes hardly a few seconds just to palpate the abdomen before you start the procedure. And typically, the C-sections for breech are scheduled at around 39 weeks of pregnancy. This is a quick video where we are going to see how a C-section is performed for breech. The anesthesia, the incision is the same. Once we open the lower uterine segment, all we have to do is to insert a hand inside. And if you look at the video very, very carefully, these are the same steps which we follow when we are performing assisted vaginal birth, assisted breech delivery. So here the assistance does help by applying gentle pressure over the fundus. Here we rotate the baby 90 degrees to deliver one shoulder, and by 180 degrees to deliver the second shoulder. Allow a couple of maybe few seconds or minutes till the nape of the neck appears, and then try and deliver the baby by Mauritius smelly white technique. And here we have to ensure that we keep our fingers on the bony prominences rather than soft tissue. We can consider doing a Burns-Marshall technique if it is easy. I personally prefer Mauritius smelly white because I find it technically easy when we are doing a C-section for breech. And of course, if you are skilled, you can always use a forceps, though literature talks about forceps. Not many of us have seen it, but we can certainly use short symptoms forceps and try and deliver the fetal head, though I have never done so. Important points we must remember about C-section for breech is that it is important to think about the incision. We can think of a J-shaped or a U-shaped incision, but please avoid inverted T. The incision must be as adequate in length so that there is no difficulty with the fetal head. We know that the breech is relatively smaller as compared to the fetal head, so make sure that the incision is adequate. The infants may be injured during the procedure, and that is something which we have to keep in mind, and we should be very, very gentle and careful when we are performing a breech delivery, even at C-section. If the lower uterine segment is not well developed, as is often the case of preterm, a low vertical incision may be considered if needed, but the surgeon must navigate the aftercoming head and potentially trapped arms gently, because the take-home message for breech is handle them with care. We don't want them to be injured during the course of birth. The next is transverse lie. Transverse lie is something which is not a very, very common occurrence, seen in about 1 in 500. But if you're dealing with a preterm patient, it could be as high as 1 in 50. And typically, it is seen in multiparous women with abdominal laxity or in an overdistended uterus where there could be multiple pregnancy or polyhydramnios. Fetopelvic disproportion also could be responsible for a transverse lie. But these days, we do get a lot more small for gestational age babies with oligoamnios where there could be a transverse lie. And of course, we cannot forget the uterine anomalies, which are responsible for transverse lie. So management of persistent transverse lie is obviously C-section. If such a patient comes in labor, you may think that if there is a conversion of a transverse lie to a vertex, you may think of a vaginal birth. But for a persistent transverse lie, C-section is the treatment of choice. It is considered as safest for both mother and the baby. And even now in modern obstetrics, even if the fetus is dead, it is considered the safest for the mother. Neglected transverse lie is something which we used to see earlier, not of common occurrence, especially in the metros. But here we have to understand that there could be a prolonged labor. The lower uterine segment is many a times thin or even ruptured. There could be fetal impaction and intrauterine infection present, and the fetus may be in distress or even dead. So C-section and intensive therapy with antibiotic is important even if the baby is dead. If infection is severe and widespread, hysterectomy may be necessary after C-section, and these are some of the important counseling points for women who come to us with a neglected transverse lie. Of course, we do not do any kind of destructive procedures these days. A short video. So here, please make sure that you do a quick palpation of the abdomen on operation table just to find out where the fetal back is, because then when you understand where the back is and where the head is, you don't really have to struggle. So all you have to do is to try and put your hand inside, try and catch hold of the heel of the foot, and then deliver the baby by a breech, and the other steps would be more or less the same. And when the back is anterior or back is superior, I should say, the things would be easy. But if the back is inferior, then things are little different. So for a dorso-superior transverse lie, we have to make sure that we take incision properly. It is a low transverse hysterotomy, and it could be an accentuated curvilinear incision so that there is no extension into the broad ligament, and the surgeon standing on the same side as the fetal head then attempts to grasp the fetal feet and perform a footling breech extraction. If you're dealing with a patient where the back is down or it is a dorso-inferior transverse lie, then it is more difficult to deliver than the back up transverse lie because the fetal parts are difficult to grasp. One consider doing an intra-abdominal version to convert the transverse lie into a cephalic or a breech. And if the liquor is adequate, probably you are able to do it. But if the liquor is completely drained, if the uterus is practically grasping the fetus, it may not be difficult. But here we have to try and understand that we have to catch or access the breech and try fetal head if you're not able to do so. There are technical challenges in C-section for transverse lie. Many times it could be an advanced or obstructed labor. Lower segment may be poorly formed or even very, very thin. Liquor is many times drained out and baby could be jeopardized, especially if you're dealing with a woman who is in obstructed labor. And the anesthesia challenges cannot be forgotten if the patient is not NBM or dehydrated, and we may have to administer uterine relaxant if you're not able to maneuver the baby inside the uterus. So coming to the baby delivery in C-section for transverse lie, the surgeon has to be experienced, but there has to be an expert assistance as well. Palpate the abdomen before starting the procedure, decide a plan, generally deliver the baby by breech, look for feet and do a breech extraction, reach into the cavity to identify and grasp the posterior leg or foot, and then perform a gentle traction to convert it into a breech extraction. Rarely, vertex, if the head is not accessible, can be tried to we can try to catch the fetal head and beware of a hand popping out at the incision. Of course, these women do require immediate care and you need to administer uterotonics as appropriate. Watch for postpartum hemorrhage because these are the women who would end up with postpartum hemorrhage. And then we must look for color of urine. These are some of the general principles. I'll finish in 1 minute. These are some of the principles that we must keep in mind. Adequate incision, uterine relaxation using either isoxaprine or nitroglycerin. And if there is general anesthesia, we have to use agents like sevoflurane to make sure that there is adequate uterine relaxation. Quick word about brow. There is a mentovertical diameter which tries to enter the pelvis and then it cannot negotiate. So most of them do require C-section. All we have to do is to flex the fetal head and then deliver it. There are chances of extension of incision, so be careful. Face presentation, again, something which is quite rare, 1 in 600 to 1 in 800. And when there is a complete extension, the presenting part is face with the denominator as the chin. Mentor-posterior positions are the one which are unlikely to rotate, and these are the faces which do get stuck under the symphysis pubis, and then they are unlikely to deliver vaginally. So here we also have to keep in mind that if there is a mentor-anterior position with non-progressive labor or persistent posterior face or even mentor-transverse or pelvic disproportion, we have to think of performing a C-section. To conclude, C-section for abnormal presentation is frequently the safest standard route to avoid obstructed labor, birth trauma, or umbilical cord prolapse. Elective C-section is typically planned around 39 weeks of gestation. Obstetricians may require a slightly larger or tailored incision to maneuver the baby out of the abdominal cavity, and the abnormal presentations do carry a higher baseline risk of cord prolapse and difficult deliveries. So consequently, continuous fetal monitoring is vital if the labor begins unexpectedly before a scheduled procedure. So thank you very much. And once again, thank you, Team ICOG, for having me here and giving me an opportunity to present this lecture. Thank you.
I will just say one line for you, Dr. Parag. You are an organizer's delight because you have covered every single point that really we wanted you to speak upon. Not hurried, totally every slide was readable, beautiful, and a man with loads of practical experience. I'm so thankful to you. It was fantastic.
Thank
Over
you.
to
So
you,
I'm
Chairperson, sir.
I'm a director's person. आपने direct किया and I just performed. That's it.
Thank you, Parag. Thank you.
Thank you, Sheila.
for participating.
Thank you.
Thank you, Parag sir. Lovely videos.
Thank you.
Thank you,
Not
Parag.
mine, and I must thank Shashi Kabra for helping me out because somehow I was not able to download these videos also. But Shashi was kind enough to send me these and I could use them. Thank you, Shashi.
Thank you,
Let's
sir.
begin with.
Thank you, sir. Thanks a lot. Now I request Dr. Poonam Mani ma'am to introduce our next speaker, Dr. Manjupuri. Shreya, will you please put on the slide, TV slide? Shreya, please put on Dr. Manjupuri's CV slide.
Good evening, everyone. There is a lot of. I am in the
Dr.
road.
Poonam Mani ma'am, are you there?
Hello. Hello.
Yes.
Hello.
Yes,
Yes,
ma'am.
yes.
Yeah. Some disturbance is there because I am out of the city. And Manjupuri ma'am, welcome. It is my pleasure to introduce you because we are a student and your student is my student now. And you are great teacher. And their topic is excellent and their program is excellent. I think best wishes. And you are an amazing person. And of course, you are academic very high. You are professor and professor of Department of Obs and Gynae, SGT Medical College, Gurgaon. And many award you get it. FOGSI Movie Call Award on 2022 for best
Thank you,
scientific
Dr. Vani. I think we can start with the talk. Thank you so much for a very kind introduction. Yeah.
Thank
Very
you,
kind
Manjula.
and affectionate introduction. Yeah.
Thanks for joining in, Poonam.
Yeah. So I will be sharing the screen. I hope my screen is visible. It is full screen and it is visible.
Yeah. Yes, ma'am.
And I'm audible, right?
Yes.
Yeah, right. So after that wonderful set of talks by Mitra, Dr. Pandya, and Parag, so now I will move on with the talk on disimpacting the head safely, techniques for safe fetal extraction. If we look at impacted fetal head at cesarean birth, it is a challenging obstetrical emergency. There is no consensus on the definition, and the impacted fetal head is described as a cesarean birth where the obstetrician is unable to deliver the fetal head with their usual delivering hand. We put in our right hand and deliver, so we are unable to do that, and additional maneuvers and/or tocolysis is required to disimpact and deliver the head. So it is not exclusive only to second stage cesarean section. That is what we need to know. 50% of the times, it may be an impacted fetal head in the late first stage. So impacted fetal head may complicate as many as 1 in 10 unplanned cesarean births and 16% to 32% of second stage cesarean births. So approximately, if we look at it, 1.5% of all births, we will end up having impacted, fetal head. The incidence of cesarean section in labor and at full dilatation is increasing on account of changes in professional training, lack of confidence to conduct assisted vaginal births and use of instruments, use of epidural analgesia, perceived safety of cesarean birth, fear of litigation, and maternally driven due to socio-cultural factors. By the time they reach the end, they say, Doctor Sahab, abhi cesarean kar do. And the doctor also gets worried, and that is how the impacted fetal head, an encounter with impacted fetal head comes into play. So this is an extremely stressful clinical scenario for the mother, her family, and the obstetrician. Now, what are the problems of deeply impacted head? So the lower segment is thinned out. We all know it is thinned out edematous. So there risk of tears, extensions, broad ligament hematoma, bladder injury. The cervix is taken up. So there is a risk of having a cervical or vaginal incision. I'm sure those who have done many cesareans would know that we have given vaginal incisions. The liquor is all drained out because the patient is in advanced labor and the head is all jammed up.
So there's difficulty in introducing your hand and in extracting the baby, as there is little space for introducing the hand between the pubic symphysis and the fetal head. So what are the complications? The complications are increased risk of extension of the uterine incision, hemorrhage, bladder and ureteric injury, increased risk of fetal head trauma, skull fractures, subgaleal and intracranial hemorrhages, hypoxic ischemic encephalopathy and rarely perinatal death, medico-legal litigations, increased risk of recurrent mid-trimester loss in the subsequent pregnancies, and spontaneous preterm birth in subsequent pregnancy. Can we anticipate this condition? Well, of course, there are certain risk factors. In case they are present, we can always expect that we might have an encounter with impacted fetal head. So one is prolonged first stage, when the labor is going tardy, it is taking its own time. Fetal malposition, especially if it is occipito-posterior. If we have needed to augment labor, the labor has not gone on its own, it needed augmentation, a failed instrumental delivery, obese moms, use of epidural analgesia, suboptimally motivated and counseled mothers undergoing labor. So initially they get motivated, by the end of it, they kind of decide that they can have no more, and less experienced obstetricians. So what are the techniques of preventing and managing a deeply impacted head? There are two pre-incision interventions. One is when you end up with a failed instrumental delivery, do a manual vaginal disinfection before you shift the patient to the OT, or if the patient is already in the OT. The second is a new gadget which has come, which is fetal pillow. I have never used it, but it has been advocated to be used in research settings. It is a kind of, a balloon kind of a thing which you can put in the vagina. And if you fill it up with saline, it pushes the head up. And then there are certain techniques in case it is already happened, then what do you do? So one is that you can use, there are certain methods of extraction. One is abdominal cephalic disimpaction. Delivery is one thing and abdominal cephalic disimpaction is another thing. So here you have to take a few precautions, which I will list in the next slide. You can use uterine relaxation. NTG is what can be used because it is short-lived, because we are also worried about PPH in these cases. So we have to give something which has got a very short half-life. Abdomino-vaginal disimpaction. In case only the cephalic disimpaction is not successful, we can add on the vaginal push. Then we have a reversed breech extraction. That is a pull technique. We have a Patwardhan's maneuver. That is also a pull technique. That means we are not fiddling with the lower segment. We are just extracting the baby by arms, starting with the arms or with the feet. And then, of course, you have an option of extending the uterine incision. This is only when you have decided for a reverse breech extraction or a Patwardhan's, where you have given a low incision, then you want to go up and catch out of the feet, then maybe you can make it a J, or maybe you make it a U on either side. In any case, the lower segment here is distended. So it is quite wide. So make a good U and you will be there. So this is how the pre-incision vaginal disimpaction or a fetal pillow works. So if you look here, what is important is that, you can't ask them to push the head like you do a PV examination with 2 fingers. So the whole hand has to go into the along the sacral hollow, and you have to cup the hand, and the hand should be resting on your palm, and you give a push. So that is what is disimpaction. And this is what a fetal pillow looks like. So it has got a platform on which there is a balloon kind of a thing which can be distended with the help of saline. So it pushes the head up. Now coming to the procedures which you will do at the time of surgery. The first is abdominal cephalic disimpaction. So if the head is already deeply engaged, make sure that you anticipate difficulty. So have the mother in frog position. So frog position would mean that low lithotomy position with legs wide apart, so that an assistant is already there who can push the fetus from below, right, if required. Not that you will ask them to push it right in the beginning. So go stepwise. We need to give a Trendelenburg tilt to the table, maybe a 15-degree tilt. Introduce your hand gently between the lower uterine segment and the head, preferably from the anterolateral side. Anteriorly, there is no space. Okay, we know that the transverse diameter of the pelvis is longer as compared to the AP diameter. So put your hand on the side and then slip it anteriorly. cup the hand with your hand, cup the head with your hand. So you have to put the whole hand below the head, okay? And make sure that you keep flexing it, okay? Like we would want a flex head to deliver from below. And, when you introduce your finger, sometimes, if you just put in your hand once and then bring it out and put it the second time, it breaks the vacuum. Otherwise, when you put in your hand, please spread your fingers. Once you spread your fingers, the vacuum gets broken and then you slip them anteriorly. Another important thing is that you need to pull the head towards the mother's head. Okay, what we do is we put in a hand and immediately try to, take the baby out of the incision, which is, higher up or which is at that point. Here, the head is gone deep in. So if you try to take the head out of that incision right at that place, like we do it in other, deliveries, here there would be a stretch at the angles and it will tear off. Is it right? So we have to first disimpact. So we put our hand, cup our hand, go down, and then make sure our wrist is straight, our arm is straight. So you have to be on a footstool, okay? So that you can put your arm straight and start looking at the mother's head so that your arm is straight and your hand is straight. Put it below and then disimpact. So you have to first push the head towards the mother's head and not towards the ceiling. So that is how it is. And you can also use your non-dominant hand, which would be easier. Here you are facing the feet of the mom and you are on a high platform. Put a hand straight and then you can, disimpact it and then you get it. Once it is under the incision, then you flex it and get it out. So that is how, what is all about abdominal cephalic disimpaction. Avoid to deliver the head during a contraction. That is also a very important thing because the uterus is contracting. So if you, give an incision and try to force your finger, sometimes when the uterus is contracted, you can wait for that contraction to pass and then kind of take it out. And also you can consider tocolysis. Remember, you have 3 minutes to deliver the baby. From the uterine incision to the delivery of the baby. 3 minutes, 180 seconds. So you have to be prepared and then you can do it very easily. So what are the other options? We can deliver the baby as vertex. Okay, it is the assistant is pushing from below. You can do it shoulder first or you can do it by breech extraction. So abdominovaginal procedure, I've already explained it to you. So this is how, the hand has to be cupped and pushed. It is associated with perinatal skull fractures, likely due to poor technique, including using 2 fingers instead of the whole hand. Then you have a reverse breech extraction. It is associated with limb injuries, including femoral and humeral fractures. So these are the steps. So first you catch hold of the foot, bring the foot and the body down, okay? And then rotate the body towards the midline and take the arm out. And then the other arm out. And then take the body towards the mother's head and then deliver it. So this is like Dr. Parag was saying, we have to do the same methods, like maneuvers which we use, and this will cause least injury to the baby. And then we come to the shoulder first, which is our own Indian method. And sadly, we do not have any evidence to support this method, but we use it so frequently. So Patwardhan's method is the one which is the method of choice. We all use it. So here it is best when the back is anterior, the head is deeply impacted. So we have to make sure that we give the incision higher. We don't have to go low down. We give the incision high, just below the reflection of the peritoneum. So once we have given the incision, a wide incision is given with the edges, curved up so that it does not go laterally. So once it is there, we will just have the shoulders just below the incision. So that is what we are going to see. Then we will see whichever shoulder is available. Whichever shoulder is available, we will deliver that shoulder first. So here, this shoulder was available, the right shoulder. So, so the shoulder on the right side. So gently you bring it out. You have to be very gentle. Then you can apply a little traction onto the opposite side. Don't dislocate the shoulder. You just have to apply a bit of traction, which should be firm, and hold it with the help of a dry mop. And then go above the other shoulder and bring it to the midline. See how nicely, easily, comfortably it has to be controlled position. And then we easily, would bring the other arm out. In the flex position, we are not extending it. We are not hooking it. And now the baby is like a butterfly. Is it right? So now you are just going to hold the baby with your fingers and thumb encircling the chest. And you are not applying traction. You are just bringing it out, and the assistant is pushing the fundus, and the baby comes out like it's like a toothpaste being pushed out of the tube. So it comes out, so you don't have to pull. So it is the baby just comes out, and then the feet have to be lifted towards the mother's head so that the head comes out the way it had gone in. So this is, the extension is very, unlikely. And then it can also be done when the back is posterior, because it is basically a shoulder first method. So here in this condition, it was occipito-posterior. So when you put in your hand, whatever comes first, you take out. So here the arm is come out first. When we were students, we had to push this arm in and then catch hold of the foot. So let it be out and then get whatever comes next. So the next is the foot which is come out. Then again here, we have to give the assistant has to give pressure on the fundus. And now you don't have to take the legs towards the feet. Take the leg towards the head of the patient. So this was what was done wrong here. So take it out and the baby would come out. So this is what is back posterior. So there are lots of papers which have been recently published in the American Journal, in the European Journal, and in the British Journal on the impacted head, because the numbers are increasing, right? So this is a very good meta-analysis which you can go through. I will not go into the details. So it compares the vaginal disimpaction versus reverse breech extraction, and it tells us that reverse breech extraction is safer as compared to the vaginal impaction as far as the maternal injuries are concerned, which looks logical. But there is serious risk of bias and lack of certainty. As far as the neonatal outcomes are concerned, they are equivocal. And when we look at the vaginal disimpaction versus Padvardhan, we have very few studies on Padvardhan and none from India. So there's lack of robust evidence to recommend one over the other. So this is to show you that, we just have two studies, and that too also from, other countries, not from our country. Then we have fetal pillow. There is lack of robust evidence establishing the efficacy and safety of the device and should not be used outside clinical trials. And this is the algorithm. I just want to take just a few seconds. Please go through it. It says that you must anticipate, you must prepare. Okay, so anticipation is all the risk factors which I told you. Preparation means senior obstetricians, team briefing, and having nitroglycerin ready, and appropriate table height, step available. And if you want to do a pre-incision disimpaction, you should do. Once you diagnose the head is not coming out, by the standard maneuver, declare an emergency, like we say PPH, call for help, right? It should be like that. Clearly, calmly declare it as impacted fetal head, and then allocate one team member to talk to the attendant, the birth partner of the patient. And then you have to pause and consider tocolysis, wait for the uterus to relax. You can even consider tocolysis, and you can try again. And abdominal cephalic disimpaction, all the precautions taking like I told you. And you can also consider changing head. If your right hand is not working, do it with left hand, and also give a call to the senior person. And then, once you have already informed, and also call for your team should know. They should be like a drill. They will call a neonatal person. They will be getting ready for postpartum hemorrhage. And then you change the approach. So you can do a vaginal disimpaction with that, or you can do a reverse breech extraction. Okay. And you can repeat all these and consider Padvardhan's maneuver in case, this is from the British, Journal of Obstetrics and Gynecology. So they are not trained in Padvardhan's. For us, Padvardhan's is a very easy and a safe procedure. So to sum it up, impacted fetal head is an obstetric emergency that needs to be managed with a multidisciplinary approach. We should do it as a drill, right? Please go through these algorithms once again. Algorithm should incorporate key non-technical skills, I think, which Dr. Mitra and Dr. Pandya has said. So it requires coordination, and it requires communication. Is it right? You can't ask, get me a stool, table low karo. So all that has to be inbuilt, right? Anticipation and preparation, declaring the emergency and calling for help, and the need to pause before, both for situation awareness and uterine relaxation. Additional methods to facilitate disimpaction include vaginal disimpaction, reverse breech extraction, and Padvardhan's method. So don't panic. You have all these methods in your armamentarium. There's a lack of consensus regarding which method for disimpaction is safest and most effective. Training on simulators must be provided to enhance the skills of obstetricians and midwives to manage this situation optimally. Thank you for patient hearing, and thank you for overshooting by 2 minutes. Thank you so much.
So I said in the outset, no, how to make complexity into clarity. That's what you are expert at. Manju, thank you so much. And over to you, Manisha. We have
It's
11
always
minutes,
a
but I would rather
delight to hear,
we can
ma'am.
give the panelists earlier, just
It's
like Dr.
always a
Manju
delight to
answered.
hear,
Yeah.
ma'am, such a comprehensive presentation. I don't think there will be any doubts left, but still I request also Dr. Jayanti Thamaya, ma'am. We will like to prepone the panel discussion so we can all have a
Because
good
we can have,
discussion.
and
So
Dr.
I
Manju is
request
here
Dr.
only,
Jayanti Thamaya,
and
ma'am,
Dr.
to
Parag
conclude the
also.
session.
Jayanti
So they
ma'am
can
has
all
not
answer on
joined,
the
ma'am.
chat box.
Is not there. Manju, it was an excellent presentation, and Patwardhan is something which is so close to our heart, and you explained it so beautifully well that I'm sure people will find it more and more useful as far as delivering impacted fetal head is concerned. In general, it is a method of choice at so many places because I've visited different states, and all of them have talked very nicely about Patwardhan because it is easy to perform once you start doing it. And when it comes from a teacher like you, that I'm sure it will add a lot of confidence to uh, the delegates' mind, and then they will resort
I
to this
think that
method.
one
Thank you.
sentence which Dr. Manju said, I think the whole ICOG and you, Parag, and Dr. Manju, and in our newer girls, everybody is doing Patwardhan. Only thing is that we are not documenting it and presenting it. So, Manisha, don't nod your head.
No,
You're
what I
part of
feel,
the talk.
Mitra,
Yeah.
what
Yeah.
I feel is, I would like to introduce Dr. Parag as one of the relatives of Dr.
Yeah.
Patwardhan. And, I think now that we have ethical committee constituted for ICOG, we can have a randomized control trial,
Yeah,
a
so
huge
that
one.
sentence that you said,
A
that
huge
there is
one.
no evidence,
Yes,
the onus
yes.
is on you and Dr. Parag to bring that evidence internationally so that we
And
get
Mitra,
yeah.
we can finish that RCT in no time. We have so
Yeah,
many
yeah.
patients.
I think
And so
everybody
many
can give
people
a
are doing.
heads up. Dr. Prateek,
Yes.
you are the chair, secretary, and Dr. Sheila, this is something which is the outcome at the end. On the third day, we will take out what all can we do as a whole group, Thank you,
Absolutely.
Manisha and Indira.
Yes.
Please bring in our panel
Thank you, Mitra, and
moderators.
I have answered all
Ma'am,
the
our
questions that were asked to me in the chat box already.
Yeah, you've already answered. I've seen.
yes. Thank you, sir, for that. Our heartfelt thanks to all our distinguished chairpersons for the expert moderation and valuable insight through this. Now, I welcome both our moderators for the panel discussion, Caught Unawares Nightmare Referrals at 2 a.m. So, I introduce Dr. Rashmi Baga ma'am and Dr. Mumtaz madam for the same. Dr. Rashmi Baga ma'am is a professor in PGI Chandigarh with over 270 publications in national and in international journals, along with many chapters in books. She got the Dr. Usha Saraya Oration Award in 2026. She is president of OBGY Society of North India, FOGSI, member of FOGSI Oncology Committee, and so on. Madam, welcome to this. Welcome for the session. And now I would like to introduce Dr. Mumtaz, madam, who is professor in MES Medical College, Kerala, who has 2019 Wonder Foxian Award to her name. And she also has many awards to her name. Now I would like to introduce the panelist for the session, madam. Panelist, Dr. Savita Rani Singhal ma'am, probably she is not able to join the panel discussions. Next is Dr. Arup Kumar Machi, sir. Sir is immediate past president of Isopops and presently professor in Shanti Niketan Medical College, Bolpur, West Bengal. He has his book is very famous in our West Bengal, Bedside Clinics in Obstetrics, Bedside
All over
Clinics
the
Gynecology.
country, Manisha, all over the
Yes, sir.
country.
Then next, Dr. Pushpa Jangare ma'am. Pushpa madam. She is
Madam is on.
professor and HOD in
Amravati.
PMD से Amravati College, the region, instrumental in establishing first human male bank in central India, Amravati. Bodankar Samman Award in 2012 and 2013. So next, I would like to introduce Dr. Anjali ma'am, Anjali Khanare ma'am. Priya, next please.
Madam is
a
professor in Churayu Medical College.
Professor and head in CMC Bhopal and president of Association of MP OBGYN Society,
Yes.
May 2026, and past president of Bhopal OBGYN Society. Next, I will like to introduce Dr. Swati Rathore ma'am. She is also professor and head in OBGYN Department of Christian Medical College, Vellore, and she is secretary of the Vellore OBGYN Society. With 17 years of experience in teaching and all, she is her special interest on high-risk pregnancy. I would like to introduce Dr. Geeta Devi, ma'am. Dr. Renu Yadav, ma'am. She is also medical superintendent and senior consultant. And Dr. Geeta Devi, ma'am, who Dr. Renu Yadav, ma'am, medical superintendent, senior consultant in Shabravati Surgical and please, Shreya, please, Dr. Renu Yadav's ma'am's CV. Previous slide, please. Dr. Geeta. And
okay, I will.
Member of Indian Medical Association.
One line. Those who have been with me, they know Dr. Renu Yadav. She is a very, very fantastic surgeon and in private practice. And we have Dr. Geeta from Vijayawada. They are all my serious, sincere teammates from Practical Obstetrics Committee. So, friends, my choice of these panel moderators and the panelists was to have people from all era. Thanks to Dr. Sheila Mane. Our moderators, one is from North and one is from South. All our panelists are covering medical colleges, private practice, corporate sector,
now
Dr. Geeta and Dr. Renu. So basically, and of course, Dr. Parag, Dr. Pratik, Dr. Manju are here to fill in. So over to you, Dr. Rashmi and Dr. Mumtaz.
Dr.
Thank you very much for the kind introduction. Dr. Mumtaz and I had decided we have actually a total of 4 cases. Depending on the time, I will start with the first case. She'll go on to the second, and then I'll come back if there is time. So I'm going to now share my slides. Just I'm collecting. Can you see my slides? Yes?
Yes, ma'am.
I'm just going on full. Can you see my slides?
Yes.
Okay. So I have actually put down the names of the panelists also for the questions. But in case someone is not there, anyone else can pick up the question. And when I am speaking, I cannot see you all. So it will be up to you. So the first case is this is a real case in the last month only. And it was a case of traumatic PPH, which is one of the worst one which we have seen in PGI Chandigarh. So she was referred 4 hours after a vaginal delivery. She had 4 living issues. She was referred with massive PPH and attempted repair of vaginal and cervical tears and presented to us with hemorrhagic shock. BP was not recordable. Heart rate was 150. She also had severe metabolic acidosis. She was already intubated and her hemoglobin was 5 grams. However, she was catheterized and there was 200 ml clear urine in the back. The uterus could be palpated on the abdomen, intermittently becoming atonic, but there was no free fluid. She was a thin lady, and the local examination showed a vaginal pack in situ with ongoing bleeding through the pack. So the first question is steps of emergency management. I have written Dr. Savita Singhal's name if she is there. Otherwise, anyone can take up.
Yeah, Dr. Geeta, you can take it.
Yeah, first we have to resuscitate with IV fluids. Thick bore needles are there or not, gray we have to put if they are not already there, and start infusing and infusing with ringer lactate or normal saline, and send for blood cross matching, and alert massive transfusion protocol also, and keep everybody alert. Send for obstetric code blue in your ER, and try to shift her. Meanwhile, you can investigate her. She's already having severe acidosis. Alert the anesthetist, shift to OT.
Yes, so very correctly, everything has been pointed out. So that was done, and her output was maintained. But the anesthetist put her on triple inotropes because it was not able to bring up the BP with 1 or 2. And we also gave her a broad spectrum antibiotic, meropenem, which is a choice in women in shock, and tranexamic acid. Inside the OT, the first on call, now Dr. Mitra had specifically asked me to point out, when the second on call is called. So it is right there. And in this case, the second on call is also going to be in a soup. So the vaginal pack was removed. The tears were repaired, lacerations were repaired, whatever they could do best. And they also gave uterotonics. So side by side, the gynae team was doing what they could vaginally, and the anesthesia team was managing to correct her acidosis. A Bakri balloon was inserted. At this time, they realized that hemorrhage is not stopping. So the second on was called. So in this scenario, if you are called, what is your plan? This I have written Dr. Arup's name, if he's there.
If Dr. Arup is there, then fine. Otherwise, Dr. Pushpa, you please take.
Yes. Okay. Thank you, Dr. Mitra, for helping out, because when you're presenting, you cannot see anything.
I know the problem. Don't worry.
These zooms.
So far, all the medical and surgical maneuvers, which were not surgical but other maneuvers, they were carried out, including the balloon tamponade in situ.
Yes.
That means
everything was done vaginally till now. Everything was done vaginally till now.
One second. Shreya, please unmute Dr. Swati. He's our panelist also.
Done, ma'am.
Yeah, please.
Right.
Yeah.
So now what remains to be done is further management, that is to remove the culprit or carry out devascularization surgery. But before that, we should confirm that patient is not in coagulation failure by carrying out rapid coagulation profile. And once we are sure that she is not in coagulation profile, we should go ahead and carry out laparotomy and go ahead with, I would prefer in this patient, she was para 4, leaving 4, straight away obstetric hysterectomy so as to remove the culprit.
Correct. So thank you. And so actually when the second on call came, the patient was still in a lithotomy position. So she was able to locate a rent in the posterior fornix high up, which had been missed by the previous team due to whatever reason, ongoing bleeding. So she proceeded with laparotomy. The repair of rent from above was attempted, which didn't work. Hysterectomy was proceeded with. And this after hysterectomy also, the oozing continued from the vault and the vaginal areas. Then she proceeded with bilateral internal artery ligation. Despite that, the bleeding continued. And the coagulopathy part, although the correction was being done simultaneously, she received a total of 9 blood, 4 FFP, 4 platelets, 4 cryos, vitamin K. That was also ongoing. So they had to do a damage control surgery. They had to pack her up and close her up. So they put abdominal packs and they put vaginal packs and they closed her up. Post-operative period, despite all this thing, the vaginal trickle persisted and triple inotropes was still required. The anesthetist was not able to reduce this required. So now what will the second on call do next? Hysterectomy is done now.
Ma'am, can I take?
Is done?
Yes.
Dr. Anjali can take this. Yeah, please.
Okay.
Madam, I think we should start looking for our extension of team here.
Yes.
We need interventional radiologists if they are there on board.
Absolutely. Absolutely. You hit the nail right on the head. Right.
Yes.
So just anything else you would like to add? Okay. So I'm going to now, the answer is correct, but just remember, we have done the bilateral ligation of the internal like arteries, anterior division. So the interventional radiologist role has to be there. Does it still have a role even after ligation?
Yes, madam, it does have a role. If we have attended complex cesarean section and the vascular pattern, which has been taught by Dr. Mitra Saxena, madam, and Dr. Manjupuri, we should realize that the vaginal bleeding is not by the S2 segment. It is by the lower segment, and that has to be taken care of. And already the laparotomy has been done. So now we need to, we can't, like, we don't want to reopen the patient unless and until the intervention.
If you reopen, there's nothing to do because you've already done the hysterectomy, you've ligated the arteries. So I don't think there's much you can do inside. So you are correct in saying that the role of intervention radiologist. So she was taken up right away with the packs in situ, with everything there. She was sent there. And I have managed to get 2 beautiful pictures from them for this case, but I would really like to share because that's the first time I'm also seeing those pictures of intervention radiology for this such a case. So what they found was internal lights were completely cut off, but the lumbar collaterals which come from the aorta were filling the internal lights distally. The left tubo-ovarian was also a bit, oozy. They embolized that also. And thereafter she was taken to the ICU and the other things were corrected. So these are the 2 pictures. On the left side, if you see the yellow arrow, this yellow arrow is pointing to the lumbar branches coming from the aorta. And this green arrow is pointing to the segment of the internal iliac which has been ligated. And this red arrow is pointing to the distal segment of internal iliac which is filling from below despite ligation. This is a rendered picture of the same case where you can see this ligated area and a filled up internal iliac artery from below. So they proceeded to embolize wherever they could find any flush. Wherever they found flush, they embolized that. And with that, the bleeding stopped. And to summarize her outcome, she had a re-laparotomy after 24 hours to remove the packs. She was weaned off the inotropes on day 2. She had a burst abdomen, small bowel extruded, and a Bogota was applied. And on day 18, we sent her home after teaching her husband how to do the saline wash of the Bogota. So with that, I end the first case. And Dr.
May I
Mumtaz
intervene?
can take over.
Hello.
Yeah.
What
Yes.
if the radiologists are not available for this interventional radiological procedures? Because they are not present everywhere.
Yes.
Where such patients are managed. So
you will have to refer her. You can't do anything.
Once
You
we're
have to
back, then
keep-
everything
that is the only option then.
I think, Dr. Rashmi, one thing is for sure. This was a nightmare when received in the middle of the night. And it is better that you see these nightmares in medical colleges. So for the general people like me, please don't try to correct a patient in shock with tears. That's my message to all my colleagues of standalone. Recognize at the earliest this patient is just a prototype of how we can lead escalation in the management. So fantastic case, Rashmi.
Absolutely. When you told me, I was on vacation, and when I just came for one
Thank
day,
you
I
so
found
much.
this happening. I followed
Yeah.
her every day, and actually, ever since the complex cesarean workshop, I've been looking for evidence to say that internal ligation doesn't work. And my colleague from radio diagnosis just shared this picture
No,
with
no,
a request
brilliant,
that
Rashmi.
share
Beautiful,
and do
brilliant.
not use it.
Brilliant,
So,
Rashmi.
those
Brilliant.
pictures are
So
really
proud
brilliant.
of you.
Excellent.
So
Excellent.
proud of you.
Yes, there's a question and I can answer that. The aortic clamp could have been used. I forgot to add, during the laparotomy, manual aortic compression was done to control the bleeding. So whatever, that's why they managed to reach a level of packing.
Yeah.
Rashmi, may I add? One more thing I will remember from our workshop where we attended at Kozhikode. It is the inferior mesenteric vessel which supplies the posterior wall of the uterus and posterior part of the vagina.
Yes, yes.
Inferior mesenteric and middle rectal, I think. Through middle rectal, they have shown one case scenario also.
Yes.
We ligated that and ultimately the bleeding was controlled. Is there such thing in this case?
Dr. Rashmi.
No, it was, they did not find a flush over there. They did not find that vessel to be there. And just remember, this was not a case of placenta accreta, where you will have too many collaterals. This was just a case of postpartum hemorrhage involved tear and cervical tear. So probably in those cases, the collaterals are more, and they didn't find a flush there. But just to tell you, in one case, we had this problem. They had embolized the middle rectal, and 2 weeks later, she had developed a rectal fistula. Because those are end arteries. So if you embolize that to control the bleeding, we have encountered that patient. Then she needed a colostomy and so on. But that every method has some of its hazards also.
That's when you did your case. I was thinking, what about her coagulation parameters? If they are not controlled in time, also she could bleed more.
Yes, we have an excellent blood bank. The moment we say activate the massive transfusion protocol, whatever they have with them is given to us. So you can see, I told you so many packed RBCs, cryoprecipitate, FFPs, as well as platelets. Everything was being given to her, and the anesthetist was continuously monitoring by the coagulation parameters and correcting whatever.
Frequently, you must repeat those coagulation.
Yeah, Renu, you please.
They do it every few minutes.
Dr. Rashmi, I'd like to add something.
Yes, please.
Actually, this we are dealing with the S3 segment. So the fault had been at the level of the second leg protomy.
Yes.
This was a S3 segment bleed.
Yes.
So actually in the second time the first time when the patient was opened up, she should not have had a peripartum hysterectomy. They should have gone ahead with in the space of Ritzius, you go ahead there. Put the bladder behind, investigate that space of Ritzius. There the whole vagina can be seen. And all the rents could have been taught.
It was a posterior rent, not anterior.
Yes, it was a posterior rent. She did try. She did before the hysterectomy. She made an attempt to take sutures from above, because one more thing, she was in the lithotomy position all throughout. She was never straight. So there was somebody helping from below to guide the rent. 2-3 sutures were taken, but the patient was not getting stable, and by this time, atonicity had set in completely. The uterus was flabby. So
I agree that we should not try to conserve a uterus where the patient is already unstable. Getting the uterus out was a very sensible decision, and let's go on to the next case.
And whenever we have a mortality, the first question asked, why was hysterectomy not done in a para 4 living 4? So that was also another reason.
I think best management was done. That's why the patient was saved. Mumtaz, please start your case.
Yes, ma'am. Yes, ma'am. This is a very short case. So whenever there is a problem, when we are caught unaware in the middle of the night, sometimes we even think about calling the lawyer. Nowadays, we also think about calling some bouncers. So that is how the scenario goes with our lives, day-to-day lives. So this is a second gravida who is referred from periphery as a case of failure to descend. On examination by the first on-call, uterus was acting, cervix is fully dilated, vertex, she was doubtful whether it is at 0 or +1, and there was caput and molding. So just a brief introduction. We know when the head is deeply engaged, when we do a cesarean section, there can be very difficult scenarios coming up, like a difficult extraction, birth asphyxia, tears in the lower segment. And is my PowerPoint clear, or is an overlap with the first slide?
No, it's clear.
So how long do we assess, and how long can we wait when this patient is fully dilated with head seems to be stuck? And though we have the new WHO labor care guide telling us about 2 hours, 3 hours and all that, active pushing for 1 hour and all that, we have to also take into consideration what the consequences of atonic PPH and the birth asphyxia that is going to happen. And we might require more blood transfusion. We may have to call in a urologist. All those problems can happen. So I would like to ask the,
Dr.
panelist, how would you like to deliver this fetus?
So first thing, I'm Dr. Swati here. First thing, it's going to be a difficult cesarean section. Already she's fully dilated with the bladder distended. Definitely the first call has to call for the help. You should have one, a senior type of assistant, or the surgeon should be there. Anesthetist should know that the complications can be there. The blood bank should be informed already. The nursing staff also should be there. And definitely your pediatrician or the neonatologist should be on the floor who is going to take the baby. Definitely it is going to be difficult cesarean section, and the bladder will be higher, pulled up. The lower
How would you
segment
like to deliver the baby?
Yeah. So how you deliver out? I think with the head is vertex at a zero station, you can deliver out easily with the cephalic. But if you're having a difficulty because the head is jammed up, then you can go ahead with the Patwardhan method. What Dr.
Is there
Manjupuri
anybody among our esteemed panelists who would like to do a push method? No, I think.
Yes, push method in this case, she is already having molding and she is already having capute. So how much it is going to be effective is
and how to push.
questionable.
This is not the way we should push. This is how the pushing should be done.
In fact, Patwardhan method would be best, as we are going to take the
there.
incision much above than the usual one.
Yes. Who will do the pushing? It is not going to be another gynecologist. We may have a very junior nurse on the floor who is going to do the pushing, who doesn't know anything about where to push and how to push. So if you put our hand and take out the fetus, we have to remember that the hand is going between the head, which is jammed, and also with the thinned out or edematous lower segment, which might break. So it is ideal, as our panelists told, to go for a Patwardhan method. And this is a case of Patwardhan method. When I opened the uterus, you would have seen the shoulder there. So that is one thing we have to keep in mind. If the shoulder is popping out at the incision, so one hand is taken out. This is for everybody, like the audience. I am just showing this video. And after the other hand is also taken out. At this point, we have to stand facing the head of the patient and keep both our hands in front of the chest and slowly bring out the baby. Once the breech is out, you can just pull the baby, and there is no fundal pressure given in this case, and the head comes out. And you can see it is not an asphyxiated baby. And we should also have a look at the uterus. There are no tears in the lower segment.
The advantage of Patwardhan method is it compresses the chest. So that is beneficial to prevent asphyxia.
Yes, and it only promotes flexion. At no point there's an extension to the fetus. And this is how the steps are. Like at one point, with both hands are outside the uterus and baby is lying like that. So,
can I add one thing more to this?
Yes, please.
And I will take opinion of all the seniors, that whenever you're planning Patwardhan, shouldn't you place the abdominal skin incision also higher up? Instead of penicillin, if you take a Joel Cohen, you are higher up, and then you open the uterus also higher up, and it becomes easier, no extension.
And so as already the modified Patwardhan video is shown, I am skipping it. Any pre-op assessment you would like to ask the first on call to do before deciding?
Swati madam has already elaborated on that in details.
Okay. So
everyone concerned should be
head to perineum distance is a key thing where we can see whether this can be delivered with a forceps or better to do for a cesarean section. When the distance is more, we know the more chance of cesarean section and acidosis. Another important point may be to know the position. When the patient is in labor for so long, it is difficult to find out the exact position. There also ultrasound will be helpful, because if it is occipital posterior, one thing good is that sometimes the head is not that low, and we can deliver by as it is, the usual method. And too low incision can sometimes inadvertently enter the vagina and also cause much hemorrhage. And also we shouldn't be so forceful in a hurry to deliver this baby. So Patwardhan or modified Patwardhan is basically an intraoperative incision decision. When the shoulder is at the incision, Patwardhan would be the best. And occipital posterior, as we know, sometimes the head is not as low as it seems to be when we do the pervaginal examination. It is a little bit high. Would you like to have any comment on fetal pillow? Is anyone using fetal pillow? So this is something that has come out recently, where we can push some fluid and the head will go up in position. And it is available in some centers. It is not available in our center, but there are people who use this fetal pillow, which is kept below the baby's head. And when the saline is pushed, about 180 ml is pushed, the head ascends up into the pelvis and we can deliver the baby without going deep into the pelvis. So this is my first case. Second case is a case of APH. After Rashmi Madam, I will be talking.
Yes. Okay.
Thank you, Dr.
Thank you.
Just
Thank you
stop
for
share
that.
here.
I'm going to again share my slides. Share. Yeah. So can you see my slides?
Yes.
Yes. Right. So this is a case of placenta accreta spectrum. This was a 32 years lady with a previous 1 cesarean section and live issue at 31 weeks who came in the middle of the night with vaginal bleeding since 4 hours, painless bleeding. And that cesarean was done 2.5 years back. So she had one child who was 2.5 years old. She was conscious, oriented, stable. Fundal height was corresponding to gestation and her vulvar pad was soaked with fresh blood. The labor room team stabilized this patient, arranged for blood and put an IV line and did a maternal placental assessment, fetal placental assessment by NST, USG, gave corticosteroids, and they also gave anti-D because we were RH negative. At this point, the senior resident did an ultrasound and found an anterior placenta previa coming up to the internal loss. Now, the decision point over here was whether to do expectant or delivery. And as the patient was stable, they informed the on-call consultant, who also agreed that we can try expectant right away, but they also wanted to know the ultrasound features which the resident had seen to let us know whether it was adherent or not. So, Dr. Swati, can you just list out the features?
Yes.
Yeah.
So first thing is the previous NSCS placenta previa. Definitely you have to look for the margins. It means between the bridging vessels between the uterus and the bladder. If it is anterior and it is going towards the bladder side, the bridging vessels, it means it can be placenta accreta. Second thing is the thinning of myometrium and the bladder. The space between this, it is going to be thinned out. Third thing is the vascularity will be very high if it is an accreta. If you are seeing a layer, the demarcating layer between the uterus and the myometrium and placenta, then definitely it is a good sign. If it is not there, there is a dehiscence is there, or there is a haziness is there, it means there is an accreta. Especially in the cases of previous LSCS with placenta anterior, you have to look for, you have suspect the accreta in the cases.
Right. So previous one also, there's a 10% risk of being accreta. So like Dr. Swati has listed out the features, I will not go into detail. You need a grayscale and you also need a color Doppler. And this was the picture of this patient. As you can see very large lacunae, you can see vascularity, and you can see vascularity in the bladder interface, but not really bridging vessels. But the lacunae are too big, too many and too big. And quite a bulk of the placenta is in the lower segment. So the consultant tried to do a pass scoring. We follow a pass score from 0 to 20, and anything above 15 is a difficult case. This was above 15 only. So then she gave the consultant on call some rest for 2 days. And just to mention, in our hospital, the protocol is that if you have any percnita coming at any time, the second on call is also informed so that they are alert that any time they'll be called. 2 days later, she had received the steroids by them. She had a second bout of bleeding, which was quite a bit. Within an hour, she had soaked 4 pads fully and it was ongoing. And now the second on call was informed, which is our policy that any accreta, especially with a pass score which is high, is not taken up by the first on call alone. The second on call will be on the floor or washed as per need. So now the question for Dr. Geeta, how will you prepare? You are the second on call and you have the ultrasound pictures. So how will you prepare for her emergency surgery?
First, we have to resuscitate the patient. She lost so much blood, the first one, and send for labs and arrange for blood and call your team. By now, your team must be ready. We must have some surgeon who is experienced in doing past surgeries
Yes.
And they are a urologist or an oncosurgeon you can involve, or a vascular surgeon. By now, your team must be ready because she got admitted few days ago. And you have to keep the team ready. And if her bleeding stops and vitals are not on the downtrend, you can wait and watch it. So
the first time the bleeding did stop, but this time it was not stopping, so they decided not to take a chance. So
this time I think you can go ahead because already steroids were given, magnesium sulfate also you would have given.
Yes, magnesium sulfate will be given now. And now, as you mentioned, we have to have a team approach and two experienced surgeons. Here, we always say that it's not one surgeon and one assistant. Both are surgeons doing equally from both sides. Now, the question is, she was previous one cesarean. Would you like to do a cesarean hysterectomy or would you do a fertility sparing option?
Doctor,
and how will you decide, Dr. Renu?
Dr. Rashmi, actually, we should be ready for everything, but our antenatal ultrasound could also have helped a little by seeing the extent of the placental margins on the lateral side and covering on the cervix also. So if we could have managed that little part of the myometrium is observed in ultrasound, we could have
So my pictures didn't show that, but this was not going laterally. This was just in the middle, but it was coming almost up to the cervix, internal os on the pictures.
Okay,
Yes.
and then we will do the anatomical decision has to be taken during surgery itself. So when we open up, we have to first open up from the round ligament on both the sides, and then go below and see the how much the bladder is attached to the lower uterine segment. How can we separate it, or is it stuck onto it? And if we can separate the blood vessels which are in between the lower uterine segment and the bladder, then we have an area of the uterus which we can observe that if there is a margin below, then we can think. So we have to see the extent of the excreta on the lateral sides and on the lower sides, and then we can decide that if there is margin of myometrium all around, we could think of a fertility sparing, like one step cesarean section only, and preserving the uterus.
So that is something which we have been thinking and seeing and doing this year after the workshop. But in this case, cesarean hysterectomy was done. But because actually there was really no space. The reason for doing a cesarean hysterectomy was because there was no space. There was no myometrium available above the cervix to suture with that, although it was not going laterally. And the books do list once conservative management with placenta left in situ, which was not possible in this place. And the concept of colpouterine arteries has now come up in a big way, which help to control all the blood bleeding from the lower segment, which is the S2 segment, which are the three arteries which are ascending, one in the middle and two laterally, which should be ligated, which help to control the bleeding. And if it is a focal, we can do focal resection also. So any step on the surgery, any comment on the steps of the surgical steps by Dr. Savita Singhal for a cesarean hysterectomy?
Dr. Savita is not here. Dr. Anjali, will you like to take it?
Anyone can take.
Or Dr. Swati, Dr. Geeta, anybody.
So, Dr. Renu mentioned about bladder dissection. So bladder dissection is what we do routinely for every case, whether we do a hysterectomy or a conservative surgery.
Yeah,
so
steps can I tell?
Yes.
First thing is we have to surgically stase it once we open it and go medial to the round ligament, extend that peritoneum caudally and cephalocaudally, and check whether any lateral involvement is there, and check and enter the retrovesical space, whether there is fibrosis is there or not, by Pelosi technique, and try to approximate both your fingers. If you are able to approximate that means there is no fibrosis. It's not type 4. So then you have to ligate the uterovesical pedicles. You have to ligate before you deliver the baby. So all vessels you have to ligate either with the vicryl or with cautery you can manage. Then only you do upper segment hysterotomy, and you have to pass your hand inside and find out the membranes. That is Bird's maneuver you have to do, and deliver the baby. And once the baby is delivered, try not to separate the placenta. Then you go to ligate the colpouterine vessels.
Correct. Right.
And if 3 criteria are met, if there is no retrovesical fibrosis and 2 centimeters of the tissue is there above the cervix, and the circumference is less than 50% involved, then all 3 criteria are met, you can go for one-step conservative surgery. If these criteria are not met, you can go ahead as your case, that is total hysterectomy. If it is type 4, we have to do modified radical hysterectomy.
So very nicely you've described, Dr. Savita. What I would just like to add one small thing here, that if you start doing this dissection of the bladder with the partially filled bladder, it was easier because you can delineate its boundaries better. In fact, we have published this approach as an upfront bladder dissection approach from our institute in about 90 cases. And we found that, as you said, the results are quite good. So the next question is, what is the role to control hemorrhage in such a case? Like a second on call is finding the hemorrhage is not getting control. The maneuvers listed: internal ligation, uterine balloon catheters, aortic compression. Any comment on all of these by Dr. Arup? Is Dr. Arup there, Dr. Mitra?
He is not there.
No, Dr. Rashmi is not there.
Can anyone take it up?
Role of internal iliac ligation in case of placenta previa accreta, which is almost covering the cervix. It is going to reduce the blood loss to certain extent, but not it is not going to take care of the whole of the blood supply. About uterine balloon catheters, it is not going to help at all. Aortic compression, of course, it is going to help till we go ahead with the main procedure. So for time being, it is maybe we can even compress it for even 60-70 minutes.
Right.
So that is to reduce the blood loss, because blood loss is going to be very massive.
Yes.
So aortic compression definitely is going to be helpful.
Yes. So,
and right from the beginning, I would suggest that when you are planning obstetric cystectomy ahead of opening the patient, it is better to do it with vertical incision on abdomen, vertical incision on the uterus. Leave the placenta alone, do not touch it, and ask the anesthetist not to give any uterotonic drugs, which we usually give as a prophylaxis for separation of placenta. So they should be totally avoided. That should be kept in mind, because we don't want even partial separation of placenta when we are thinking about hysterectomy. Now coming to this, the placenta is on the lower segment covering the cervix. So there is no question of subtotal. It has to be total. It is going to be technically difficult, but as we have informed neurosurgeon and sometimes oncosurgeon who are in better position to tackle this separation of bladder, avoiding injury to the bladder. So it is always better.
I would agree with everything you said, except for the last one, total subtotal. What we have seen in our experience is that even if placenta is covering the os, it stops at the internal os. It doesn't go inside the cervix actually. So doing a subtotal is faster. The sutures are held better in the residual cervix rather than the vagina. Vagina is more friable. It cuts through. This saves time. Bladder injury, ureteric injury is less dissection, less blood loss. So we do not persist in a total hysterectomy. We just stop till the placenta is. That is how we do. But of course, this is everybody has their own experiences. So now, like you said, I will just leave all this thing. Avoid and oxytocin, avoid everything. So this is my last slide. So the post-operative care, would anybody like to comment on this? Dr. Anjali.
Definitely. Was told by the anesthetist on his talk, the patient should be put on ventilation rather than making a hasty extubation. So if we do
extubation in a proper stepwise manner, it is good. The patient should be shifted to ICU care where one can have 1:1 nursing care with her. Her coagulation profile, massive blood transfusion protocol, everything should be taken into account. I would like to mention, madam, you have said that the patient was RH negative. So in our institute, we have a protocol where we at least put 2 blood in reserve even before the patient is, as soon as the patient is admitted, we keep 2 blood bags reserved for her, whether she has to be taken in for surgery or not. And one more thing which I would like to mention is, yes, you have rightly said, filled bladder makes the dissection very easy. We had a neurosurgeon and it was such a small trick which we were taught by him that the bladder fibers separate very easy, and what we have always in our back of our head that we may injure the bladder, that is not happening if we have full bladder. So it is really something intraoperative which we can take care of.
Absolutely. In fact, we use a partially filled bladder. We put a 3-way Foley's, and a person can help us to inflate or deflate. Usually it is done twice in the whole procedure, once in the middle, once at the end. About 150 to 200 ml urine is enough to make its, its margins very clear. Absolutely correct. And of course, our anesthetists are the best people to decide about extubation on table or not. If the surgery has gone smoothly, patient is fine, they extubate, but she should be kept in at least the high dependency unit for some hours for close monitoring. And we also give them thromboprophylaxis because they do come in the category of high-risk surgeries. But when to start all depends. If your bleeding is well controlled, you are happy, you may start 12 to 24 hours post-operatively. And we encourage mechanical thromboprophylaxis.
That box, you would like to put a drain. Yes, I'm a strong pro for drain because that gives you peace of mind that and actually I operate a lot of cardiac patients who are on anticoagulation. So I usually prefer putting a drain so that we know how much the patient is bleeding and how much you have to replace. Rather than struggling, doing ultrasound and then reopening, a small drain can make you have a good sleep in the night after such a long hours in the surgery.
Absolutely correct. This is a very small intervention, low, hardly any risk, and 24 hours of drain will tell you whether how good or how bad it is. So if the placenta is left in situ, which can happen in a very few cases, we have almost never done it with full counseling, etc. But I have come across people who do think that's a method to do it. What is the role of giving methotrexate in that situation? Anyone can comment? Dr. Geeta is there. Dr. Mitra,
after explaining all the risk of leaving behind the placenta.
No, Geeta. Let's just, Rashmi, you give the answer.
All right.
So 5 minutes, no?
Never be given. It has never given.
No role of methotrexate.
Yeah,
very
even
clear-cut message from this platform. Nothing.
Myelosuppression.
Stop doing methotrexate.
Now, wind up with this. This patient had an ICU admission. She was given broad-spectrum antibiotics. She was given thromboprophylaxis, mechanical plus pharmacologic, and we had the drain in situ. Once we found drain is showing nothing, we were happy to give her Clexian 0.4 12 hours later. And I would just thank you all.
Yeah. We have less than 5 minutes for Mumtaz to take her case. So just see how you can finish, because 6:30 we have to start the link of the questionnaire. So Mumtaz, please.
Yes, quickly.
Mitra, I think Mitra.
Yeah.
Mitra, Mumtaz can continue for another 5-7 minutes. You can put the link in between. I think that can be done. Right?
Do that. Do that. Yeah.
Yeah.
But then QR code has also to be shown. Up link डाल दो Shreya. Put the link while Mumtaz will share. And Rashmi, where are you?
और मैम timing क्या?
I'm right here.
Brilliant.
6:45 पे डालो बेटा.
Very well
6:45. 6:45 पे link डालो ना मैम?
Yeah.
ठीक है.
नहीं अभी से लिंक डाल दो कोई नहीं.
So this पर मैम मुझे टाइमर लगाना पड़ेगा फिर.
अच्छा
6:45 पे डालो. हाँ.
Okay.
A common case which any one of us might just encounter in the middle of night at 36 weeks gestation. a fourth gravida with previous 3 normal deliveries is brought with bleeding PV. Her vitals are stable, uterus is appears to be irritable, and clinically we are doubtful about the FHS. So the initial assessment by first on call, the 3 main reasons that we'll be focusing is this. Would anyone like to elaborate on how we can go to a diagnosis before we decide on the management?
So first is the abruption, because one thing is pain with bleeding PV at 36 weeks and fetal heart rates are not sure about. So first thing, it goes on the abruption. In placenta previa, the painless bleeding at any gestation, fetal heart rate may or may not be there. The local cause, yes, can be a reason for bleeding, but I'll go through more towards the abruption in this case. Only the blood pressure, we had to know how much is the blood pressure and the prior history also.
Okay, so we have to feel the uterus, look for tenderness, and if there is a labor room, ultrasound, speculum examination is important. If there is an ultrasound in labor room, maybe we can see whether there is any placenta previa or any succingerate lobe. Another important thing is we can look at the previous records. If the previous record is saying that uterus is in the upper segment, then mostly it could be a case of abruption.
Yes.
We can also locate the local reasons, and we
Yes,
should also
speculum
vasa
examination.
previa.
Yes.
Vasa previa. Cervical bleeding and vaginal bleeding is also there, and maybe she's into labor. It may be show also.
Also, and once we had a patient who had severe bleeding, it turned out to be a varicose vein in the vagina.
Yes.
So that is also possible. So second on call is called upon. Ultrasound is repeated in the labor room. It is intrauterine demise. How would you like to manage this patient? Do you
First
want
of
to
all, we
do
should do
LSES
a
or
maternal and fetal assessment actually. What are
intrauterine
the...
demise?
No. Maternal assessment in the sense of
Vitals are stable. Vitals are stable.
vitals are stable, and we should do a Bishop scoring of the cervix, see how much dilated she is, and if she's a normal patient and she's already para 4, I think so, then we can assess the pelvis and see the cervix and then go induce her.
Any difference of opinion here?
Yeah.
Patient should be catheterized first.
She is almost full term, 36 weeks, and with IUD, invariably there will be coagulation defect. That we must rule out, at least by bedside clot observation test, and we have to send for PT-INR, APTT, and fibrinogen levels. Then
So
only
intrauterine demise in abruption means more than 50% of placenta is separated.
Yeah, that is already IUD.
Yes,
So
that
I
is
expect
IUD.
coagulation defect in this case.
High risk for a
All investigations should be done.
We have to send for investigations for coagulation profile. We have to catheterize the patient, and depending upon whether she can deliver within 8 hours, depending upon how much blood she has already lost, all these things we need to first consider. So she should deliver
She's a fourth
as early as
gravida.
possible.
Once we do ARM, she may deliver within 1 hour.
Yes.
Yeah.
So if
Meanwhile,
she
we
can
can make
deliver,
arrangements for blood, everything.
Only if she is in labor. That is I would like to add that point. Only if she's in labor, already dilated some 4-5 centimeter, then we are right in doing an ARM and making her deliver because she's a multi. Otherwise,
We
if
used
you're
to do
planning
abruption, they respond quickly. She's a fourth
but if
gravida. I
planning
think she
infection
will
and then making dilation from the beginning, then it might take time, and then we might end up with coagulopathy. So these tests will take time, and as Madam has rightly pointed out, we can do this clot retraction bedside. Every labor room should have the test tube to do a clot retraction. So it turns out to be that the patient is in DIC. So the first on call calls you and asks whether we have to correct the DIC before doing the cesarean section.
All
it should be simultaneously carried out.
Yes.
Correction of DIC
simultaneously carried out. Don't wait for the DIC to be corrected because it is never going to get corrected unless you remove the placenta.
Correct.
It's not going to get corrected. So preoperative preparation. Anything else you want to add?
I think the atonic PPH is very, very common in this type of cases. Other than the massive blood transfusion, you need to have a think about what you are going to do for the atonic PPH in this type of cases. So like cochlear uterus, you can get, so you might need surgical intervention at the time, like B-link sutures and the devascularization sutures, or you might need a SR cannula. so that for a compression thing also you might need. So that is also you have to keep in mind.
Okay. If it is a cuvier uterus, should we go ahead with hysterectomy?
No, it is not
No,
indicated.
it's not
No,
indicated.
not indicated.
Yeah, it is not at all an indication. We can make the uterus contract, as you rightly said, either by the sutures or by the uterotonics or by the suction cannula. Once the uterus is contracted, it is okay. And what about drain?
Yeah, drains are the
It
must
should be
in this
there.
type of cases.
Drain is a
Yeah.
must.
Drain is a must.
Even
We always
subcutaneous
do.
drain is must, because otherwise she might develop in a subcutaneous, the rectus sheath hematoma can be there. So it is important to have both the drains in this patient. Postoperatively, we monitor the usual things, and the drain is going on increasing. You get a call. The drain is now 200. It was 100, 200. Now it is going on increasing.
All the vital
What
parameters
important
have to
things
be
you want to look into?
Fibrinogen levels and clotting factors should be looked into at this very point, and then we can see if the fibrinogen level, the hematocrit level, platelet count, they are appropriately at that very level. If they are not, then they have to be substituted.
So it is always like you have to repeat the coagulation profile. Nature of the drain is usually not fresh blood. It is that mixed with the peritoneal fluid and vitals. If it is stable, you just need to replace the coagulation factors like cryoprecipitate and FFP sometimes, and then the drain will decrease. It is not an indication to reopen the case. Unless there is a frank bleeding and you suspect there is a bleed from the
ultrasound can also
at that time you can also make use of an ultrasound to see whether there's a hematoma developing. Okay. Same patient, we did a labor room ultrasound. FHS is present, but it's a low-lying anterior placenta previa. Same patient who came with APH.
Better to go ahead with the rapid
placenta previa.
cesarean section.
Cesarean section. What complication do you anticipate in this picture?
Again, the same thing, coagulation profile, we should be on lookout of this
Placenta
and be
previa.
prepared to correct it simultaneously when we open this patient. And she is likely to have postpartum hemorrhage.
And she can have very prominent vessels in the lower segment because it's a case of placenta previa. So how would you like to tackle these vessels? Would you cut it or would you coagulate it? Would you tie it? Your experience?
No, we can ligate the uterines bilaterally.
No,
Yes.
before delivery of the baby.
And no,
Yes.
not before. We should
have
rapidly
to ligate these vessels first.
If the vessels are interfering with our incision site, maybe
Yes, we have to
then of
ligate
course
these vessels first.
Yes.
in that case before
How to
removing
reach
the
the
baby.
fetus?
We actually,
This is the picture.
you
Do
know
you want
what?
this
We
placenta?
have to map the placental edge by the ultrasound and then see where the edge is. And the upper edge, you just make an incision, go between the myometrium and the placenta. Don't go inside the placenta, between them, and then reach the amniotic fluid and then take the baby out. The edge of the placenta will not bleed at all. And then later on, it can be taken.
Preoperative mapping of the placenta and find out where the membranes are.
Membranes.
The ward maneuver.
Then
Wards
go through the membranes, cut the membranes, and never try to go cut the placenta and then deliver. It's not good.
Delivery of
Because
the
it
baby
will
might take
exsanguinate the
time.
baby.
Delivery of the baby might take time. It may be a high floating head, it may be a transverse lie, and if you cut the placenta and there's also a delay in delivering, then we are in trouble. So it can be a high floating head or transverse lie. High floating head, how do you prefer to deliver?
Best is we let the LICA drain out, the head will naturally come down. Either if it is a preterm, we have to use forceps. If it is a term baby, we can use a ventouse also.
So any comments on how to use the forceps?
Forceps is we open up the forceps by putting a finger. If the head is down, definitely. If it is just holding the assistant will hold the baby's head, and then we can by the right side we go towards the fetal ear, place one side on one side, and then place the other handle on the other side and gently lock it, and then gradually guide it through the incision. It should not be sort of pulled. Pressure from above and gently guided through the incision.
So it is posterior and anterior insertion. It's no right and left as we do in the vaginal forceps application. So once we open up, we have to we do this is the pelvic in any direction. In this baby, the pelvic curve is pointing towards left, but baby's back is on the right. This is for demonstration. So once you open the uterus, you put your hand in between the head and the posterior myometrium. So this is a meconium stain like this is a big baby in labor, extending the uterine incision with scissors so that you're sure about the adequacy. So the posterior blade, it goes between your hand and the head. The assistant has to hold the posterior blade firmly, otherwise it is going to slip. Then you retract the anterior myometrium and insert the anterior blade, and the baby is delivered. So even if it is a pelvic curve is rotated, this is, I mean, again for demonstration purpose, babies, we don't usually apply like this, isn't it? We are all right. When we are right-handed, we apply it facing toward the left of the abdomen. This is just to show, even if you apply in any direction, the only thing that one has to be posterior, one has to be anterior. It's a high floating head with hydramnios, and the baby can be delivered without any fundal pressure or any delay. And if it is vacuum, we have to go to the flexion point always, and then apply. In case if you are applying towards the anterior fontanelle, baby's neck will be extended and a larger diameter is going to present at the uterine incision, and invariably the uterine incision can get extended. So that should be avoided. You go to the head, go to the flexion point, I mean towards the occiput, and then the assistant has to retract the anterior abdominal wall and the anterior part of the uterus and apply the vacuum cup as close to the occiput as possible. And then only the pressure catheter tubes, once you confirm that you have not got anything, and then you can, once the pressure is up, you can deliver the baby without any fundal pressure or without any difficulty. So that is the cup at the occiput. So imagine how else, once we are delivered, we have removed the placenta also, and she is bleeding from the placental site. Can you elaborate on these methods of how to stop the bleeding from placental sites?
We can use transverse B-Lynch also, and we can ligate the colpouterine vessels from below, from the ones from the cervix. But usually what we are doing when the suture is applied, we are giving figure of 8 sutures on the area where it is bleeding.
What suture material, ma'am?
Sorry?
Which suture material, ma'am?
Generally, I'm using vehicle number 1.
Catgut is also very good for the
One zero catgut is also fine when you give a suture inside the uterus.
Yes.
That will also be used. Compress the area where the open sinuses are there. Sometimes that will stop. Uterine artery can be ligated, and as we were discussing about the colpouterine, as madam rightly said, we can ligate these vessels, because sometimes even if you do the cesarean section, you can see the lower segment is getting filled up.
Yes.
Cervix is closed, lower segment is getting ballooned up. What to do? So we have to actually tie these vessels. And when the upper segment is completely contracted, the usual Hamans and B-Lynch is not going to help. So any comments on how to control this ballooned out, how to tackle this ballooned out lower uterine segment?
Actually, we can give a transverse B-Lynch suture. Transverse B-Lynch suture can be given. That is Dr. Jose and Dr. Albaro had described in their videos.
So transverse B-Lynch can be done. And in case if we are a junior person, like we want somebody else to come, we can give this uterine, tourniquet can be applied.
Yes,
one thing, the assistant has to hold the uterus up, and we can apply a tourniquet below the level of the bleeding. And also we can give aorta compression.
Yeah, transverse B-Lynch or Chose sutures also we can apply. Then Comax sutures we can apply. And then Ashok Anand stitch also. The
vertical. The idea is to compress the two walls or stop the blood supply, and locally, because this is a distal we are dealing. We don't need to go proximal to the uterus. We are going to save the uterus. I think that was brilliant.
And to summarize, abruption, we have to think, mainly we have to think, because we have dealing with DIC, we are dealing with economics, brain should be there, blood components. Placenta previa, both brain and our skills, physical skills are important regarding baby delivery and how to arrest the bleeding. And in deeply engaged head, always have a plan A or plan B. We should be ready if one method fails, how to deliver the baby. As a last resort, we can even extend the incision if you're not able to deliver the baby. That is the last thing we should do, because it is going to cause damage to the uterus. If your incision, uterine incision, is corresponding to the shoulders, the best would be to do the Patwardhan. But if you're getting head there, then you can deliver the baby as usual method. Pushing the baby from below, if you have a gynecologist doing it, maybe it is okay. But it's again, unless you pain the vagina, this patient is at a high risk for postpartum endometritis. So that should also be taken into consideration. Thank you.
Can you hear the clapping?
Thank
For
you.
Rashmi and
Thank you.
Mumtaz.
Thank you.
Thank you. Thank you all the panelists for your very expert comments. Thank you very much. And
Thank you, Dr. Mitra,
Thank you, Dr.
for
Mumtaz.
making us part of this wonderful.
And
One second, don't
certification.
leave the station. Abhi, Shreya is going to share the
Yes, ma'am.
link.
Thanks to the moderators also. They have planned a very well real-time experiences and practical challenges that we face. They have discussed all. Now it's time to post the
link,
post-test link. It has been posted in the chat box. Delegates can have 10 minutes for answering the post-test. And you are supposed to score at least 50% marks on 3 days to qualify this certificate course. The QR code is also displayed on the screen. And we will display the answers after 10 minutes.
But after the participants submit their form.
All the participants should submit.
Meanwhile, I think Dr. Sheila, please
only for
unmute
15
Dr.
minutes.
Sheila Mane.
It will only be for 15 minutes.
Link for test is in the chat box, all the members. What I was really scared, Manju, was the nightmare cases. But they have come out so beautiful.
Very nicely done
Smartly.
panel.
Rashmi and Mumtaz.
Congratulations to
I'm very
both
proud. Very
Dr. Rashmi and Dr. Mumtaz. Excellent.
Yes.
And all the talks were also very nice. So we request all the participants who have participated in big
Please
numbers
unmute
to
Dr.
be there
Sheila.
tomorrow also.
Dr. Sheila.
So do come
Thank you
in
for
time tomorrow.
making us a part of this program, Dr. Manju, Dr. Mitra. I really appreciate.
Shreya, पहले Dr.
It
Sheila
was our pleasure. Yeah.
co-host बना दो.
मैम कर दिया है मैम.
डॉक्टर शीला को स्पॉटलाइट भी कर दो.
हाँ, yes. हेलो.
डॉक्टर शीला को स्पॉटलाइट करो. हाँ जी डॉक्टर शीला. 906
नहीं,
people
बहुत
stayed.
in time आप लोगों ने खत्म किया, बहुत ही अच्छा. And panel also went on very well. Thank you, Dr. Rashmi Bagga and Mumtaz. So मित्रा, आज तो you have क्या बोलते हैं ना उसको, हीरे चुने हैं सब. Thank you, Dr. Geeta. I saw Dr. Geeta also. Thank you for joining. Dr. Pushpa also from Amravati. So all the zones are covered.
Thank you.
Thank
You are happy,
you
we are
for
happy.
the opportunity.
Thank you all
Shreya,
of
please
you.
put the link again and again.
I
thanks
take the
for
privilege, ma'am, as a coordinator to propose the vote of thanks to today's very successful day one of our ICOG masterclass on complex cesarean. I express my sincere gratitude to all our senior ma'ams, sirs of ICOG office bearers for their visionary leadership and unwavering support. Dr. Sheila Mane ma'am, Dr. Parag sir, Dr. Mitra ma'am, Dr. Manjupuri ma'am, Dr. Pratik Tambe sir, and all other senior faculty members, to all our speakers, Dr. Sunil Pandya sir, and other faculty members, the esteemed chairpersons, all the panelists, and a special thank you to Dr. Manisha Bajaj ma'am, who is also my senior from Lady Harding. And we had almost 1,000 delegates today who had patiently been there with us throughout the sessions and now are answering the questions of the post-test questionnaire. And last but not the least, to the entire ICOG office team for their flawless execution and being behind the scenes. Thank you so much. And we look forward to see all of you again for tomorrow, day 2 of our ICOG masterclass. Thank you, everyone.
Very, very good attendance. I think maybe more than 1,000 also, because sometimes in medical colleges, no, they are all watching together.
Yeah.
So, yeah,
हाँ.
yeah. So, good number
इंदिरा
of
अपनी
people.
पोयम सुना दो. इंदिरा ने एक पोयम लिखी है.
Okay, okay. सुना दो, सुना दो.
अभी लोग क्वेश्चन आंसर कर रहे हैं ना, आप सुना दो, फटाफट सुनाओ. इंदिरा कहाँ चली गई?
Yes, ma'am.
जल्दी
Before
से
we
सुनाओ.
before we part, let's walk once more through everything we gathered and more. We began before the blade was drawn, in checklists made at early dawn. Each box a promise, each tick a vow that safety walks before us now. We spoke of blood arranged, not chanced, of units matched and cross checked, advanced. For the moment crimson flows, preparedness is the calm that shows. We sat beside our anesthetist friend, two minds, one patient till the end. Their needles' ease, our knife's own grace, are stitched together in one space. Then came those babies turned away, the breech who would not face the day, the transverse lie, defiant still, each asking patience, a guided skill. We spoke of heads deep locked, unmoved, where gentle push and patience proved that force is not the answer here. Technique, not strength, dissolves the fear. Obstructed labor, silent tense, taught us to read the moment's sense, to know the line where hope must yield, to steal and skill upon the field. And placenta previa's crimson wheel pass beneath where risks prevail, reminded us that hands that heal must also plan for what is real. So is this first day folds its wings, remember, surgery is not just what a blade brings. It's the checklist ticked, the blood kept near, the calm we hold when danger's near, the hands that turn a baby right, the patience through the longest night. Tomorrow waits with more to learn, but tonight let this thought return. Every mother that we see trusts not our skill alone, but our humanity too. Thank you so much.
Very, very nice.
Very nice. The whole topic, today's topic covered. Wow. क्या
Wow.
talent है.
बच्चे हैं ये बहुत
Very
बढ़िया
nice,
वाले.
Indira. Very
And
nice.
she's going to become a professor in a couple of days. Dr. Sheila, please give your blessings, all the seniors. We're going to have that interview.
Yes, yes. Definitely.
So, Dr. Manju, can
Come to Bangalore, Indira. Ask her to come to Bangalore now.
Thank you, ma'am.
And I take this opportunity to invite once again those who are attending today, and almost 1,000 people. Welcome to Bangalore for ICOG conference, 21st, 22nd, 23rd August. Again, we have hands-on complex caesarean section workshop. We have hysteroscopy, fetal medicine, IUI and ovulation induction. And 2 days of conference. Almost 100 people are going to take fellowship in Bangalore, FICOG. We have 3 honorary fellows receiving, and there are orations. So it's a great scientific event. Welcoming you and inviting you, all of you to. For details, you can access the ICOG website or call any one of us. Okay? We are there to help you.
So, Shreya, how many forms have been submitted?
Mitra, we can share the answers tomorrow. Maybe tomorrow. So
Manju, you can finish off now. You can read
Okay.
only the answer because they'll be waiting for that.
Okay. All right. So, no, but then the link has to be, stopped. Only after
No.
that we can read the answers.
After that only.
Yeah.
After the link is...
Right. Done.
That time.
Got it.
Everyone submitted. Okay. So, I think after half a minute we can do. We have 6
we can
minutes.
stop the
No, they will stop the link once the time is over. 10 minutes
Okay,
ticket.
okay.
Not to no. They will wait. You have to wait.
Okay.
मंजू आराधना से बात हो गई क्या?
हाँ हो गई, हाँ जी हाँ जी. So she will be there for one of the stations.
Yeah, ठीक है.
हाँ जी हाँ जी.
So the good thing is that all the master class, everything is on the ICOG online website. And tomorrow the link for the master class of PAS will also be put up. And this all these sessions are
It is the same
recorded
link.
and
Same
they will,
link.
yeah.
Yeah.
हाँ नहीं मैडम, मैं ये कह रही हूँ कि पास मास्टर क्लास जो we did on 21st May, there were a
it
lot
is
of
there on the
queries.
website.
Yeah, there were a lot of queries today. So I'm just letting everybody know.
अच्छा, master class वाला. I got it. Yeah,
because
yeah.
we are not covering pass in too much details, but it is already there, concentrated. So tomorrow again, dear friends, please join and another brilliant sessions by all our fantastic faculty.
Those who were not able to join today can still join for 2 days. Okay.
The videos will be uploaded on ICOG website after the 3 days course.
4 minutes left, ma'am.
One thing I would like to say that as many as जितने भी cesareans कर लो, every cesarean is a new cesarean. So every time we develop a new skill with every case. So thinking that I know all cesareans is actually absolutely not right.
The biggest learning that I would like to share with the whole audience, and Dr. Manju, I will need your comment at the end. Savdhani hati, durghatana ghati. And every cesarean, please think this is your only chance to not make a mistake. Because I have seen that the younger age group people, they are in a hurry. ये करना है, अभी 4 पेंडिंग है. प्लीज पुट बिल्कुल अर्जुन बन के उस केस को अच्छे से निपटाओ, उसके बाद दूसरे का सोचो. अदरवाइज व्हाट इज हैपनिंग इज too many cases, you want to do fast, you are going to make a mistake. Dr. Manju, your comments for the audience.
Yeah, so from my side, I think it is important. It is not only doing the surgery, but also being able to defend and have a genuine indication, a pre-op assessment, risk stratification, preparedness, checklist, and doing the procedure, and then post-op follow-up. So that means doing surgery is only one part of it. Rest all is even more important. So that is why Mitra is right when she says Savdhani hati, Durghatna ghati. So Savdhani from pre-op assessment to intra-op to post-op. All this is important till your patient goes home.
Yeah.
One patient came to me. She went to another consultant in a government hospital. She told, your BMI is 45. I don't want to handle your case. You please go to higher center. I mean, when you don't have a backup, okay. I mean, you really worry that alone emergency. So she came to me, they're refusing like that. I said, yes. I mean, if you're they can think, if she comes at night and some problem happens and koi help nahi hai, itni obesity hai. So as Dr. Manju said, preparedness. I mean, we have to have a team ready if we really have a complex case, obesity or whatever. Particularly obesity is becoming so common now.
So
and
I would like to
anticipation,
add,
Dr. Sheila,
yeah,
anticipation.
yeah.
Preparedness से पहले anticipation जब ध्यान से नहीं देखेंगे तो anticipate नहीं करेंगे, right? So that is what.
मैं मैं एक और इंटरेस्टिंग बात ये बोलना चाहती हूँ कि वी ऑब्स्टेट्रिशियंस हैव अ वेरी बिग ईगो. हमारा एनाकोंडा जो है ना, हमारा जो ईगो का एनाकोंडा है वो बहुत बड़ा होता है. बट व्हेन वी आर वर्किंग इन अ स्मॉलर प्लेस, दैट इज द टाइम यू शुड नॉट ओवरशूट. तो कीप योर ईगो लेस. मैं डायलॉग जो बोलती हूँ पेशेंट को, आई वांट टू शेयर इट विद एवरीबडी. आई एम इन अ स्मॉलर प्लेस, सो ऐसे नहीं, सर्जरी तेरी मैं कहीं भी कर सकती थी, मेरी जगह छोटी है. डोंट डाउट your own competence just because you have to refer a patient timely. So these things are for all private practitioners. Do not jump the gun just because it is only a cesarean. Like Dr. Sheila and Dr. Manju said, I think that doctor was very intelligent to know her limitations. So that's it. I think now it's over. The lectures will be available, but your test will not be, Dr. Ashima.
One small case I would like to share that recently one patient was referred from a periphery, a cesarean, day 15 with subacute intestinal obstruction like features. So with mild fever. So I thought it may be sepsis, and there was a hematoma written in CACT, subserosal hematoma. There was some hematoma inside the uterine cavity also. But finally, it came out to be a pseudo aneurysm in the cervix. And after embolization, she absolutely recovered, which I have not seen, though I am very young amongst all the faculties. But I thought it is not that.
That is pseudoaneurysm in cervix is really rare.
Yes.
Right? Yeah. We have
Okay,
seen
now
in
you.
uterus. Yeah, take the answers now.
Yeah, please tell the answers. Shreya, please put
Should
the
I
answer
read the
key.
questions also and then the all options and then answer, or just ABCD?
No. Only the correct answer.
So question number 1, at what gestational age is a planned cesarean section typically scheduled for a woman carrying a breech baby? Answered at 39 weeks or later. Second question, when performing a cesarean section for a breech presentation, which step among the following is most important for the surgeon to keep in mind, as the surgical extraction may be much more complicated than for a cephalic presentation? The surgeon must navigate the aftercoming head and potentially trapped arms. Then, which of the following conditions is at least likely to be associated with a persistent transverse lie at term necessitating a cesarean delivery? Answer is SGA baby with oligohydramnios. Fourth question, during a cesarean section for a transverse lie where the fetal back is dorso-inferior position, which is the recommended maneuver to deliver the fetus safely through the uterine incision? So reach into the cavity to identify and grasp the posterior leg or foot, then perform gentle traction to convert it to a breech extraction. Then, according to next question, according to indication-based protocols, trial of labor after cesarean prolac is contraindicated in previous classical uterine incision. In sign-out phase of cesarean section checklist, the team confirms the instrument or sponge count, estimated blood loss, that is option B. Which is the category 1 emergency indication of cesarean section? Option B, umbilical cord prolapse with fetal bradycardia. Then question 8, main goal of using checklist of a cesarean section is to reduce errors and improve team communication and patient safety. Then ninth question, an obstetrician receives an ABG report of a laboring patient with pH 7.44, PaCO2 30, HCO through 20 millimoles, lactate 1.2, resident flags it as abnormal and needs correction. What is the correct interpretation? Answer B, no intervention needed. During a difficult cesarean section, question number 10, for a placenta previa with a scarred uterus, the obstetrician becomes intensely focused on controlling a bleeding vessel and does not notice the swab count discrepancy flagged twice by the scrub nurse. So this is this failure is at which level of situational awareness? Level 1%. So this answer is D, which is cognitive tunneling effect, level 1 input. Then 11 question, an obstetrician is planning delivery for a woman with severe MS, which statement is most correct? Cesarean is indicated only for obstetric reasons. Mode of delivery should be joint cardio-obstetric decision, with vaginal delivery often preferred to avoid hemodynamic stress of surgery. Next question, obstetrician is operating for placenta creta spectrum with anticipated massive hemorrhage, requires massive transfusion, avoiding lethal pentad. So which is that lethal pentad? The pentad is C, option C, hypothermia, then acidosis, coagulopathy, then hypocalcemia, and then hyperkalemia. Maximum safe uterine incision delivery interval is 3 minutes. Option C. Sequence of fetal extraction in Patwardhan method is shoulder, trunk, shoulder,
Foot
tongue,
and
feet,
head.
head. Yes, that is option A. Then 15th question, which of the following is not a technique for disimpacting head of the cesarean at the cesarean section? Forceps. Forceps is not used for disimpacting head. Then which statement is false as regards to extraction of deeply impacted head at cesarean section? That is pull method is safer than the push method. This is wrong. Then all of the following are true in managing cesarean sections in women with obesity, except a higher chances of hyperventilation syndrome. Then challenges in anesthesia in women with obesity undergoing cesarean section. All of the above is the answer, which is difficulty in monitoring, positioning, airway management. All of the above. In obese women, when planning incision, landmarks remain the same. Pubic symphysis and iliac crest are most reliable. So B is the option. That is pubic symphysis and iliac crest are most reliable, the bony landmarks. And last question, which of these is not correct? So here 30-degree head up position increases compromise to airway. That is not correct. The head up position improves the airway. So option A. That finishes the question. Thank you.
Okay. So I think we are in time. It's 7:05. So
Sorry, Indira, for question number 16, the answer was B, not C.
you
Just
said
C.
wrong.
It was
Shreya,
that
flash it
pull
again.
method is safer. Just C. No, it was C only. She read it B, but answer was C. Yeah. The highlighted answer is correct. That the abdominal incision to baby, delivery of the baby is not a independent marker for fetal outcomes. That is false. Can you show it again, please?
श्रेया को दिखाना पड़ेगा. श्रेया, please share
Yes,
the
by mistake I read.
हाँ, उसमें कुछ आपने उल्टा पढ़ दिया था, है ना बेटा?
हाँ, मैंने B पढ़ दिया.
Yeah, so this is
16th question. The answer
which
is C.
statement is false? So the C is false, right? The abdominal incision to delivery of the baby time is an independent determinant. It is the uterine incision to delivery time, not abdominal incision to delivery time. You can take any time, right? It doesn't matter. Okay? Fine. Yeah.
So I think that's
thank you
great.
then. Thank you all.
Bye-bye. See you tomorrow.
See you tomorrow at 4 sharp. You can log in earlier because the platform is open at 3:30.
Thank you, ma'am, for the opportunity.
Bye.
Bye. Thanks, Dr. Sheila.